Tyler.
I need my glasses this morning. So good morning. My name is Councilor Chris Moyes. I am the Chair of the Board of Health. The Board of Health Secretary has confirmed that we have quorum. So I'll call meeting 26 of the Board of Health to order. Welcome to everyone who's in the room and online. Today's meeting is being held by video conference and in person at City Hall in Committee Room Number 1. Because we're meeting in person and remotely, we ask everyone for their patience with any delays and technical issues. If you are registered to speak at today's meeting, please listen for me to call your name. I will call speakers in the order they appear on the list. The list of speakers can be viewed online by visiting the Board of Health page at toronto.ca/council and clicking the speakers box for today's meeting. The Board Secretary has provided all agenda and materials on toronto.ca/council and via CMP, the clerk's meeting portal. Directors, please ensure that your video is turned on. Please keep your mic muted unless you wish to question staff or to speak on an item. As part of each agenda item, I will ask directors to raise their hand or mute their mic if they wish to question staff or speak. I will then create a speakers list and will call on directors when it is their turn to speak. When voting on an item or a motion, I ask the directors to ensure that they turn on their video and to raise their hand to indicate their vote. Directors, I want to remind you that you must submit and approve your motion by email. Staff are available at boh@toronto.ca to help with motions. The Board of Health acknowledges the land we are meeting on is the traditional territories of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. The City of Toronto acknowledges that all treaty peoples, including those who came here as settlers, as migrants, either in this generation or in generations past, and those of us who came here involuntarily, particularly those brought to these lands as a result of the transatlantic slave trade and slavery. We pay tribute to those ancestors of African origin and descent. Are there any declarations of interest under the Municipal Conflict of Interest Act? If you have an interest, please raise your hand or unmute your mic and indicate the item number and the nature of the interest. Seeing none in the Councillor Chandra Balan, Director Chandra Balan.
I have a conflict of interest for item 26.4, Downtown Community Outreach Response and Engagement. I work with Cadillac Fairview and they're looking to host the CORE program, so.
Okay. Did you submit that in to the clerk?
I have not. Do you want it in writing?
Yeah, just send something to the clerk. Thank you.
Thank you.
Next, we need a motion to confirm the minutes from our last Board of Health meeting on June 3rd, 2025. Councillor Bravo, Vice Chair Bravo. All those in favor? Opposed? Carried. So again, good morning to everyone and welcome to our last Board of Health meeting ahead of the brief summer recess, and I must say it's very brief. Today we have a full agenda of items, many of which are the accumulation of months of work from Toronto Public Health. First, I am pleased that the Medical Officers of Health hiring panel is bringing forth a recommendation for the appointment of our next Medical Officer of Health. We went through an intensive hiring process, and I am confident that the successful candidate will lead Toronto Public Health with distinction. If adopted here, the recommendation will need to be approved both by City Council and the Minister of Health before the appointment is official. Today, we will also receive the first annual update on the 2024-2028 Toronto Public Health Strategic Plan, which provides a guiding blueprint for delivering high-quality programs and services and outlines a vision for a city where all people can be healthy and thrive. It is very encouraging that of the 22 key strategic action outlined in the plan, 20 are either complete or in process. While these actions do not reflect the full scope of TPH work, I know that Toronto Public Health staff will continue to guide us towards full completion over the coming years. Through this strategic plan, the TPH has committed to advocate to advance health equity by updating progress on 3 key objectives: assessing and reporting on health inequities, collaborating with cross-sector partners to address local health needs, sharing evidence to influence actions that improve population health. One of the tools supporting this work is the Population Health Status Indicators, also known as PHSI, dashboard, which provides disaggregated data to help identify and address health inequities across Toronto. First launched in 2019 and refreshed in 2024, the PHSI dashboard includes more than 100 indicators across 7 public health topics, with data shown over time by geography and by socio-demographic factors such as sex, age, ethno-racial identity, and income group, and in alignment with open data principles. These insights help TPH and its partners monitor trends that take action to reduce health and social disparities. Today, we'll learn more about recent updates to the dashboard and the information it houses. In addition to the PHSI dashboard, we will soon have a dedicated dashboard to track climate change-related health impacts. As I am sure you know, Toronto is currently experiencing weather that is hotter, wetter, more severe, and less unpredictable than we're used to. These conditions are inextricably linked to our health in many, many ways. For example, climate change and severe weather events may worsen chronic conditions and increase the risk of the spread of infectious diseases. Changes in the environment can also impact our mental health. I am glad that staff are providing a timely update on how we're planning for climate change monitoring to understand health impacts and support resilience in Toronto. Also exciting, in the mid-pilot update from the Downtown Community Outreach Response and Engagement, also known as CORE Team, the Downtown CORE Team is designed to address the complex health needs of individuals in the Sankofa Square area and provides a proactive support to improve access to health and social services. Led by a team of public health nurses and supported by primary care specialists, the program provides short-term case management, health and social service referrals, as well as overdose and substance use responses. To complement this team of public health professionals, TPS has dedicated specially trained community-oriented police supervisors and constables to support and enhance the safety of everyone involved, including clients receiving care. The team's public health professionals, during their interactions with vulnerable community members when necessary, and the general public. All team members have received training in trauma-informed practices, harm reduction, and healing-centered engagement to create environments that support well-being for individuals. During the first 5 months of implementation, the CORE team had nearly 4,000 client engagements, including 240 that were client-initiated. This speaks to the level of comfort clients already have with the team. In severe cases, individuals have progressed from initial engagement to completing referrals, accessing medical care, and starting substance use treatment, or submitting housing applications. From these early outcomes, I am very optimistic about the continued positive impact of the core team. Thank you to Superintendent Skinner and Santa for joining us here today to share more about the program. And finally, I would like to thank Director Ozode for sharing an update from the Alpha Conference, which was hosted by Toronto Public Health and the Association of Local Public Health Agencies last month. Thank you also to all of the directors who attended and staff who supported the event. I am proud that we had the opportunity to showcase our contributions as leaders in public health. And with that, I'll turn things over to Dr. Lanty. Thank you, Dr. Lanty.
Good morning. Thank you, Chair Moyes, members of the Board of Health, and to everyone joining us in person today and watching online. I hope you've all had a nice start to your summer. In looking ahead to today's agenda, there's a clear theme in the reports of how strongly Toronto Public Health's 2024 to 2028 strategic plan is a guiding blueprint for our work as we strive for a city where all people can be healthy and thrive. Today, we will speak to how the strategic plan guides our public health planning, including developing and delivering on actions that are meaningful, timely, and fully consider the public health challenges that lie ahead. For example, considering the impact of climate change in our city, extreme weather events are not unique and will increase in frequency and intensity over the next century. Our most recent Toronto climate projections support the need for a more comprehensive way to track the health impacts of severe and unpredictable weather events. In response, TPH is developing a surveillance framework to better monitor and report indicators to guide evidence-based action to minimize climate and weather-related health harms in our city. This speaks directly to priority 1 of the strategic plan and how we are responding to the ongoing impact of climate change. Initial consultations with our partners, including other city divisions, several Ontario public health agencies, and local academic researchers affirm the value of TPH's framework and alignment with work underway within other organizations. In looking at priority 3 of the strategic plan, we focus on promoting conditions to support positive mental health and reduce the harms of substance use. In June of 2024, TPH and the Toronto Police Service partnered to launch the Downtown Community Outreach Response and Engagement Team, or more commonly known as the Downtown Core Team, a 1-year pilot program. Led by our team of public health nurses and supported by a primary care clinician, the Downtown Core Team is designed to address the complex health needs of individuals in the Sankofa Square area, as Councillor Moyes pointed out. Short-term case management, health and social service referrals, as well as overdose and substance use responses are provided to individuals in the community who engage with the program. Since the pilot launched in December 2024, there have been 3,563 engagements initiated by our public health nurses and 240 client-initiated engagements. And as Councillor Moyes pointed out, we have many examples of the positive impact at this early stage. Priority 4 of the strategic plan describes our commitment to advocate to advance health equity. One of the tools supporting this work is the Population Health Status Indicators Dashboard, or PHYSI Dashboard. Launched in 2019 and refreshed in 2024, the dashboard includes more than 100 indicators across 7 public health topics with socio-demographic data shown over time. These insights help TPH and other city divisions, healthcare providers, social service agencies, and other sectors monitor trends and take action to reduce health disparities. To capture the full scope of our strategic plan achievements, TPH recently launched a new progress dashboard on toronto.ca to highlight 22 key actions that reflect targeted efforts to advance the plan's priorities and objectives. The dashboard will be updated twice a year with our next update this fall. In closing, I want to acknowledge the amazing TPH staff, our city colleagues, and our community and healthcare partners for their contributions in the delivery of our strategic priorities and showing our progress in improving population health for Toronto. Thank you, and I hope everyone has a happy and healthy rest of their summer.
Thank you, Dr. Lanty. So we have 6 items on the agenda for today. The first item is HL 26.1, Appointment of Medical Officer of Health. This item has a report with the confidential attachment. I'm going to suggest that we hold this item down and also time it for 11 a.m. Because we have folks coming in here, okay? The next item is HL 26.2, Toronto Public Health Strategic Plan 2024-2028 and 2025 Annual Progress Report. There's a presentation, so I will hold this item down. And there are also speakers on this item. Next item is HL 26.3, Toronto Population Health Status Indicators, a tool to advance health inequities. There's a presentation on this item as well, so I will hold it down. HL 26.4, Downtown Community Outreach Response and Engagement, the core team. There's also a presentation on this item, so we'll hold that one down. HL 26.5, Planning for Climate Change Monitoring to Understand Health Impacts and Supporting Resilience in Toronto. There's a speaker on this item. Okay, so I'll hold that one down too. It's only one speaker. HL 26.6, update on the Alpha 2025 Annual General Meeting and Conference. Anybody want to hold that down? No? Okay, so Director Ozode, you want to move that item?
Sure, I would like to move the item, and do I have some time to just give a bit of a commentary on it?
Well, I could hold it, we could hold it down and then you could speak to it if you like.
In that case, let's hold it down.
Okay, so we'll hold that down. So we're holding on everything. Okay. So we'll go back to the top of the agenda. So again, 26.1 is a timed item. We'll go to 26.2. Just find my... Toronto Public Health Strategic Plan 2024-20 to 2028 and 2025 Annual Report. So there's a presentation, I believe, right? Who's presenting on this item? Okay.
Good morning, everyone. I am pleased to provide our first annual progress report on implementing Toronto Public Health's 2024-2028 strategic plan. Next slide, please. The development of the strategic plan was led by the Board of Health Strategic Plan Development Committee and informed by extensive consultations with Toronto Public Health staff, public stakeholders, and city divisions. The plan was adopted by the Board of Health in July 2024 and serves as a guiding blueprint for Toronto Public Health as it strategically navigates key priorities and ensures the continued delivery of impactful programs and services to our diverse population of more than 3 million residents in Canada's most multicultural city. Since the Board of Health's adoption of the plan, Toronto Public Health has made progress towards implementing the priorities and objectives identified in the plan. These include advancing strategic priorities through Board of Health reports and recommendations. And since July of last year, all reports to the Board of Health include a strategic impact section. This section clearly shows how each report advances one or more of the strategic plan's strategic priorities and objectives. Next slide, please. Next slide, please. Toronto Public Health staff have identified 22 key actions to move each priority forward in a meaningful way and allow Toronto Public Health to track progress of the plan's implementation over time. These actions do not represent the breadth and scope of Toronto Public Health's work. They focus the organization on implementing a select number of strategic and concrete steps over the next 3 years. Toronto Public Health staff continue to deliver core programs and services under the Ontario Public Health Standards and the Health Protection and Promotion Act that contribute to a city where all people can be healthy and thrive. Taken together, the actions and the broader work underway to deliver Toronto Public Health programs and services will continue to improve population health and reduce health inequities in Toronto. Next slide, please. Toronto Public Health has identified 5 actions that will strengthen health protection, disease prevention, and emergency preparedness. One of these actions is to develop and implement a climate change surveillance framework to better assess risks of climate change to the health of Torontonians and inform mitigation approaches. To implement this action, Toronto Public Health is developing a phased public health climate change surveillance framework. As part of this work, we have conducted ongoing stakeholder consultations and brought forward a report to the Board of Health today. Phase 1 of the framework, which will include available climate exposure and health data, will be launched in Q1 2026. A publicly accessible dashboard will be created and will share information related to the health impacts of climate change. Next slide, please. Toronto Public Health has identified 4 key actions to promote health and well-being across the lifespan. One of these actions is to increase access to healthy growth and development services for underserved populations. Multiple activities are underway to implement this action. As an example, Toronto Public Health has expanded the Into Kids Health program to 30 new schools in 2024 to 2025. The program is a collaboration with Toronto schools to create healthy school environments in equity-deserving communities. TPH continues to develop and strengthen partnerships with Indigenous-led and focused organizations, including Native Child and Family Services of Toronto. Efforts are also underway to expand partnerships with Black-focused agencies such as the Breastfeeding Clinic in collaboration with the Ancestral Midwives Collective in Scarborough, and extended service hours at 2 existing breastfeeding clinic sites. Next slide, please. We've identified 5 key actions to promote the conditions to support positive mental health and reduce the harms of substance use. One of these actions is to improve referral pathways to quality mental health supports for populations and neighborhoods experiencing barriers to access through work with health and community service providers. To implement this action, Toronto Public Health launched the Downtown Community Outreach Response and Engagement, or CORE team pilot in December 2024, jointly led with Toronto Police Service. More information about this work will be discussed in a later presentation today. Next slide, please. We have identified 4 key actions to advocate for the advancement of health equity. One of these actions is to build and share a dynamic dashboard that shows trends and characteristics of local population health information. I am pleased to share that Toronto Public Health has completed this action with the launch of the Population Health Status Indicators Dashboard in 2024. The dashboard shares indicators with sociodemographic data and currently includes over 100 indicators across 7 public health topics. This initiative provides population health information to advance health equity, and additional information about this dashboard will be explored in greater detail in the Board of Health presentation today. Next slide, please. We have identified 4 key actions to nurture a positive workplace culture. One of these actions is to develop and implement a workforce development strategy to support staff. To implement this action, Toronto Public Health is developing strategies and training to upskill staff and support leadership growth in order to foster a culture of innovation, continuous improvement, and learning. Next slide, please. In addition to identifying actions to advance a strategic plan, Toronto Public has developed and launched a public progress dashboard as directed by the Board of Health. Next slide, please. In June of this year, Toronto Public Health launched a dashboard that publicly tracks and reports on how the organization is making progress on the plan's priorities, objectives, and actions. Of the 22 actions, Toronto Public Health has completed 2, is on track to complete 18, and is scheduled to shortly begin 2 actions. Next slide, please. Here's a snapshot of how the dashboard highlights progress being made to implement the strategic priority of advocating to advance health equity. For each strategic priority, the dashboard shows the objectives outlined in the strategic plan, and the objectives are what we want to accomplish. And then to the right, you can see the action, then the status of each action in a color-coded format, as well as a brief text progress update for each action. Progress updates for each action will be updated in the dashboard twice a year in the spring and fall. So our next update is expected in around November 2025. I welcome you and invite you to explore the dashboard on our website and view the progress Toronto Public Health is making in implementing the strategic plan. Next slide, please. Looking ahead, Toronto Public Health will continue to implement the priorities and objectives in the strategic plan 2024 to 2028. The dashboard will be updated twice a year, as I said earlier, with our next update in the fall of this year. We will continue to report back each year to the Board of Health on progress made towards implementing the strategic plan, and future annual reports will profile examples of our successes and progress. Thank you for this opportunity to provide an update on behalf of the organization on our implementation of the strategic plan, and with that, I will turn it back to you, Chair Moyes.
Yeah, thank you so much, Dr. Lanty. We do have deputants on this item, or speakers. We have 15 in total. First up is Allison Stewart. You have 5 minutes or less.
Hi there, Chair and Councillor Chris Moyes. I was told that I could extend my speaking time to make a short presentation, so I will be speaking on behalf of a few speakers, if that's okay.
Sure. Can't you identify the speakers that you're representing?
Yes, Marjorie Nicol,
Okay.
Steve Glassman, and myself.
Okay. So go ahead. Whenever you're ready.
Yes. Oh, thank you. Great. Thank you very much. Oops. Allow. Hello, Chair Chris Moyes, Vice Chair Alejandro Bravo, Medical Officer of Health, and members of the Toronto Board of Health. My name is Allison Stewart. I'm the Director of Advocacy and Public Policy for Cycle Toronto. I'm here today to, one, thank you for all of the amazing work that you've been doing on advancing Toronto Public Health's new strategic plan. And I'm here to present a really awesome project that we have done called Pathways to Mobilities, connecting older adults to active transportation through biking in Toronto. We actually just had a press conference out front talking about how we can support your priority of promoting health and well-being across the lifespan. So by way of an overview of the project, with funding from the federal government's Active Transportation Fund and the ECHO Foundation, we were able to develop a program to look at what barriers and what motivations would be needed to get more older adults having meaningful opportunities to discover cycling as a mode of transportation. Some of our project goals were to build awareness among older adults through outreach to gain their insights and experiences, was to also evaluate the Toronto policies and plans that support active transportation and seniors' health and well-being, and to develop some practical recommendations that will improve access to cycling among seniors, really with the goal of improving their health and well-being throughout the lifespan. So 4 of the main insights that we gained off the top through the literature is that some of the benefits is that it improves physical and mental health, it improves balance and reduces falls. So one of the biggest health concerns among older adults is falls. And one of the benefits of biking and exercise in general is that it does help improve your balance. So the more people bike, the more their balance is improved. E-bikes, trikes, and other adaptive styles of mobility is a real game changer to improving accessibility and mobility, and a lack of safe cycling infrastructure is a big barrier. But another barrier is a lack of access to programs and support. So we consulted the City of Toronto projects and plans, and we actually also partnered with Bike Share Toronto, who helped provide bikes for our workshops. We determined that for our resources and scope, we determined that we would focus on Scarborough, because we discovered, thanks in large part to Councillor Bravo, that there was something called NORCs, naturally aging retirement communities. They are essentially residential buildings that can be condos or apartment buildings, or even communities where those buildings have at least 30% of older adults living independently. And it was actually something that came to light and was leveraged throughout the COVID pandemic to get out the vaccination clinic to vulnerable seniors. And so we identified an area, and then we assembled a group of older adult cycling facilitators. They are all older adults who live in Scarborough and who bike for various reasons and are active leaders in their community. And with them, we developed and implemented some engaging workshops where we could then go into those communities and launch these interactive workshops that included group discussions where we gave them surveys so that we could identify what were their motivations, what were their experiences, and what would it take to get them biking. We also got them out trying a bike, which was a lot of fun. We had 72 older adults participants, and once they got on the bikes, they had a lot of fun, especially those that didn't think they had the strength or the balance. And some of them, we heard comments like, "This has been my Canadian dream." One woman who said, please take a photo of me. My husband and my family won't believe that I'm biking. And also social connection. All of our workshops, after we had tried the bikes, we had some food and snacks where we continued our discussions. And really the joy, they overwhelmingly wanted to have this program continue so that they could have regular opportunities to expand their biking skills and meet others and discover their neighborhoods on a bike. So older adults want to bike. Today in 2025, it's never been a better day to bike in Toronto, regardless of your age or ability. And it's certainly wonderful seeing the growing population of older adults biking. Adaptive bikes and e-bikes, they improve access and safety. We're also seeing that it really benefits the accessibility community. Increasingly, you may see wheelchairs with an adaptive e-bike style to help them get around. They need and they want access to bikes. Most of our participants did not have access to bikes. And in fact, for those that had seen a bike share station, they didn't know how to go about trying it or if it was something that they could try. And of course, a lack of safe infrastructure is a barrier to people biking, especially older adults. So improving the public realm to make it safer for people to walk and bike is really critical. The Toronto Public Health launched a series of reports in 2012 called Road to Health, how to improve biking and walking in Toronto. And so it's the similar message about improving our public realm for older adults. Our 72 participants, 66% were over the age of 65, 31% were between the ages of 55 and 65. Women made up 67% of the participants. We say that not because that is a normal representation of the biking community. It's still it's still much more male-dominated in terms of people biking, but we think that the fact that we had such a high uptake of women for our workshops is because women do tend to get out more and are much more social. But it was great because most of them had never tried biking. And also we had a great representation of the diverse communities of Scarborough. South Asian, East Asian, with a minority of white and a mix of others. gender, race, and income, social inequities really impact health outcomes. 43% of our participants were women over 65 living in household incomes less than $30,000. 100% of the white participants had biked versus all of the others. And 48% of participants from households from 30,000 had never tried biking. So really that gender and income plays a role in who has access to biking. And one thing that's really important to note is that most participants in our workshops don't drive. They rely on public transit, in particular Wheel-Trans users. So getting them on adaptive bikes to get around would really open up their lives and make them less isolated. The number one motivating factor is that 88% of our participants want to improve their fitness. And 86% indicated that they want access to more Learn to Ride programs. And 76% of them need access to a bike. And really, the importance of building community. It's really important that if you want to help communities, you need to work with them and partner with them and make sure that you're listening to what they need and what they want. We have 6 older cycling facilitators who are also our consultants and volunteers. You'll be hearing from a couple of them today, Rhoda Potter and Douglas Yardley. But we also have Shanaz Stree. She's the one in an recumbent e-bike. She actually just biked from Toronto to Ottawa, and she's on her way to Montreal as we speak. Peter Lowe, Bryce Bates, and Steve Glassman as well. So many of them are here with us today. They were really integral. And they demonstrate that being 65 plus, you're still very much active and involved in your community. So the key learnings that we received were, 1, the need to build confidence and connection. That diversity and accessibility through trikes, e-bikes, and different styles is key. And inclusion and equity, right? How do you adapt to mobilities in different populations and what their needs are? And connecting with those communities where there are seniors biking. I mean, one of the things we actually did some outreach and went knocking door to door to these various NORC buildings to try and talk to some of the building management and some of the seniors. And so through that, we actually got to connect with them and had people come out to our workshops. We reviewed the City Toronto programs, and we discovered that there's a bit of lack of integration between senior health and active transportation policies. Senior health plan doesn't necessarily integrate cycling into that program. So whereas there's talk about how to connect seniors to walking and public transit, there isn't really a mention regarding access to Bike Share Toronto or how biking on our trails can help. We also need to redefine seniors and mobility, and even indeed how we view the humble bicycle. It really is an important mobility tool. And even though, people who bike look so different, speak across all languages, across all ages, but yet there still seems to be this trope and myth that it's reserved to one type of a population. And we also need to connect municipal policies to various community programs. So some of our 5 recommendations is really centered around expanding access to cycling programs, safe infrastructure, and expanding the diversity of bike styles. And really to help create and promote a culture of inclusive cycling culture equitably. And so specifically for the Toronto Board of Health, one of our recommendations is really to advocate and promote senior cycling programs within the NORCs and helping create those connections. Really, the people we spoke at these buildings would love to have like a regular Learn to Ride program that could gather people together and discover their neighborhoods biking. And really creating an age-friendly and equitable and healthy Toronto. We need safe infrastructure, but we really also need to show and connect people to that infrastructure, connect them to bike share, show them how it's done in the same way that we teach children and kids throughout high school how to play sports. It's something that really needs to happen across the lifespan. And really, the Pathways to Mobility project, provides Toronto with a Scarborough-centric case study, and view it as an extension of that amazing work that the Toronto Public Health did in 2012 and throughout COVID as well, on reaching out to vulnerable populations. I mean, 38% of older adults in Toronto get the recommended 150 minutes of exercise a week, and up to 40% of Canadians over 50 are at risk of isolation. One of the things that we also did as part of this project is we developed an older adult cycling guide to help encourage and educate. So on that, that's really why I'm here today, and to promote our Pathways to Mobility. CycleToronto.ca, we have our report and our cycling guide available for people to download, and we will be advocating and advancing some of our programming to encourage more seniors to bike. And you'll get to speak to some of them today as well.
Wonderful. Thank you so much, Allison. Any questions for the deputant? Councillor Chang, go ahead.
Thank you, through the chair. Thank you, Allison, for this great report. I've always felt that more investment needs to be made on the software, changing people's behavior, versus just the hardware of installing bike lanes, because behavior change is very difficult. And I'm just wondering, are there future plans of expanding the program to invite seniors into cycling? I know in my neighborhood we have lots of NORCs, and also future bike lanes slated. So just wondering about the potential of the future of this program.
Well, thank you, Councillor Chang. And in fact, you have been, we've really appreciated your advocacy and push for calling out the need for better culture of cycling, because absolutely, people need to be introduced and connected to the infrastructure and the bike share program. In terms of Cycle Toronto's future programming, we will absolutely be looking at how we can expand our existing Learn to Ride cycling programs and education work. And that said, as a registered charity, we rely on funding. And so, and in fact, it was through a grant that we applied for back in 2021 that we were able to bring this project to life. And so that is definitely something that will be in our future, is trying to identify more funding so that we can expand and replicate this project across Toronto, because there really is a demand. And one of the things I failed to mention, both at our press conference and my presentation, is that the engaging interactive workshops that we had hosted 4 of them, they took place in November and December of 2024. So not only, challenging the status quo that, older people aren't active or don't want to bike, but also the fact that you can't bike in November and December. Biking is absolutely a year-round activity in Toronto.
Thanks for that. And maybe the federal New Horizons Seniors funding could be a source of potential funding for the future of this program. And I'm just wondering if you could speak a little bit about fall mitigation, because we know that seniors, especially women who are dealing with osteoporosis or pre-osteoporosis, that one fall could be really life-changing and in a terrible way. So what are the ways that can really help seniors explore biking safely?
So that is a great question. Thank you for asking that, Councillor Chang. And in fact, I am the caregiver of an aging mother who has always been accident prone. And that said, and where she is now in terms of her mobility, one of the things that's been really helpful, both with this example, but also just in the literature, is really, it's been proven regardless of age or ability, exercise is going to improve your health. It's going to improve your strength, and your balance. And so, and in our report, we do note a couple of studies that actually outlined how people who bike more have much improved balance, right? But it's a bit of a catch-22. So you know, through physio, through doing exercises, and really making sure that you're safe before you get on the bike. And that's also where trikes come in handy, because you have the 3 wheels give you that extra stability. And one of the things that we did at our interactive programs for the Learn to Ride is just to make sure that we were taking every due caution, because these were all people that aren't with our network. We weren't sure of their abilities. And also to make sure that it was fun and engaging. Before we did the Try a Bike, we did a group exercise where everybody stood, you know, in a circle in a group, and we were encouraged to hold onto a chair. And we went through a series of exercises to warm them up, to get them moving, and also to identify what their mobility was like, right? So doing simple things like standing and leg lifts, to really identify that, you know, everyone in this room is capable of getting on a bike. And so that exercise, as any warm-up before you do physical activity, is really helpful, and then prepare them for the bike. So again, it's that it may be hard at the beginning if you're taking someone that isn't very active, and so you take a stepped approach to building up your strength and your mobility and taking a cautious approach. And that's why it's important to have supportive Learn to Ride programming with experts in the room to make sure that everybody's being safe.
Okay, thank you. Thank you. That was the last question.
Thank you.
Okay, Director Ozode, go ahead. Be mindful of the time, please. Go ahead.
Okay. Thank you so much for that presentation. And I've just got a couple of questions. So you said that the pilot happened in Scarborough. What part of Scarborough did it happen in?
We were in Scarborough Agincourt, Malvern,
Okay.
and Scarborough Southwest.
Okay. Okay. And do they currently have a cycling infrastructure there?
Great question. They have very limited cycling infrastructure. And in fact, in the areas where, in the 4 different places where we had our workshops, there was no safe cycling infrastructure. So what we did, I mean, we either, you know, we cordoned off parts of a parking lot. We also had access at a couple of venues indoors. But one of the things that we discovered, because, you know, Scarborough is known for its large, dangerous arterial roads where the majority of traffic collisions take place, but in between those arterial roads, you have communities. And so at these 4 different locations, we saw older adults biking on the sidewalk, right? The roads, they were quieter roads, there was a lot of parking, but there was also a lot of space that would make it easy to improve the safe connections in those areas where there are large concentrations of older adults.
Mm-hmm. Okay. Yeah, the reason why I was asking is because I live in the inner suburbs as well, in North Etobicoke, and I am a cyclist myself. And my worry is always about, you know, encouraging cycling, which is like a really great thing, has so many health benefits, the social connections component. I love that you highlighted that, but even just giving people a purpose to leave the house. So how then do we encourage cycling as a means of active transport or connecting when there isn't this solid cycling infrastructure?
Well, that's a great question. And so for folks who have never biked before, I mean, again, you need to take a stepped approach. You know, most of the people that participate in our workshops aren't ready to just start biking and go grocery shopping or do their daily activities. Some of them are able to do that. But for example, one of the things that's important about creating a culture of support is identifying the safe routes, right? I mean, just 4% of Toronto streets and roads have some form of cycling infrastructure, but there are some great trails, there are quieter streets. As the city has been rolling out safer and quieter streets by lowering speed limits, by investing in automated speed enforcement, by using the traffic agent program in school zones. Really, there is this growing demand for reducing the speed of traffic and creating quieter streets. And so taking that in areas such as Scarborough, where putting in a bike lane may be a few years away, there are certainly things that can be done to make the communities safer for people to get around. So for example, the seniors attending our workshops, they live close to their shopping center, close to their community center, and it's just finding ways of how they can safely partner with people to get out safely.
Okay. Thank you for that. And then my final question is, I agree with Councillor Chen 100% that the big thing is in changing the attitudes, the software versus the hardware. And so I'm curious, thinking more sustainability now, were there local community organizations outside of the cycling ambassadors or cycling champions? Were there local community organizations, even community health centers or community centers that you consulted with for this pilot?
Absolutely, great question. We collaborated with the Toronto East Cyclists. We collaborated with Danforth Kingston for All. We collaborated with the Agent Court Village Community Association, Access Alliance Multicultural Health Services, the Malvern Family Resource Center. We also reached out to city staff and reached out to other senior active living centers such as the Lamoureux Community Center and also the Toronto Public Library. So we really, once we had created that map of where high concentrations of the naturally aging communities were, we really targeted those areas with flyers. We went door knocking. We reached out to the local community to really find what we call, or normies, right? People that maybe aren't connected to the cycling community.
Okay.
Okay, thank you. That's it.
Thank you.
Good work.
Yeah, thank you. Any other questions? Okay, thank you, Allison. Even in the hot seat for 30 minutes.
Thank you.
Thank you for all that you do. It's important topic.
Thank you.
And a lot of interest. Next up is Douglas Yardley.
Yes, he's one of ours.
5 minutes, go ahead.
Chairperson, board members, thank you for this opportunity to speak to you. My name is Douglas Yardley. I'm a retired factory worker living in Ward 20. I'm 73 years old. I'm a member of Toronto East Cyclists. I volunteer for the Scarborough Cycles program at Access Alliance. I have lived without a car since 1991. I cycle thousands of kilometers every year for recreation and for transportation. I rode my bike here today from Scarborough, as a matter of fact. This has kept me fit and saved me thousands and thousands of dollars for my retirement. I urge our city to adopt the recommendations of the Pathways to Mobility Plan so that we can make our city a place where people of all ages can thrive. We need cycling infrastructure for seniors. I also urge our city to proceed with the Danforth Kingston Bike Lane project, which is supposed to have been part of the 2025-2027 cycling plan. One minor benefit of cycling is that when you're on a bike, you see things that people in cars would likely miss. Because of this, I was able to return lost property to people on 4 occasions. On another occasion, I saw 3 packs of cigarettes lying in the gutter. I stopped and trampled on them. Thank you, board members, for considering my views. I urge we need healthy seniors in this city. I hope that you will be as lucky as I have been. Being old is fun if you're healthy.
Thank you. Thank you, sir. Thank you, Douglas. Any questions for Deputy? Seeing none. Thank you for coming in today. 73. Wow. Impressive. Next up is Rhoda Potter. 5 minutes, go ahead.
Good morning, everyone. And hello, thank you to Councillor Moyes and Bravo for your leadership in championing a healthier and more equitable city, and for your support of the Pathways to Mobility project. And hello, members of the Board of Health. My name is Rhoda Potter. I'm president of Agincourt Village Community Association, AVCA, and a resident of Ward 22, Scarborough, Agincourt. I just celebrated my 75th birthday, and I feel like I am as young as I was when I was much younger than this. I've enjoyed biking for over 65 years, and I advocate for safe cycling to make it easier for my grandchildren, who I cycle with, my friends and neighbors, to discover the health and social benefits that it brings me and everyone I know who bikes. Cyclists in our community and beyond are valuing the new protected Huntingwood Avenue bike lanes in Scarborough. They may be short, but at least we have a small section. This important piece of infrastructure is helping people connect on bicycles to schools, GO Transit, TTC, grocery stores, parks, library, etc., and to enjoy safe exercise. There is work to do in helping people connect to it, and as AVCA encourages older adults to discover the benefits of biking, as well as we promote safe family cycling through community events. Our older adults have started with short weekly rides to build confidence, basically from one Tim Hortons to another. This year, on August the 16th, we will celebrate the completion of the Huntingwood protected bike lanes between Kennedy to Victoria Park at our annual Huntingwood Day celebration. With that said, the main objective of my deputation today is to draw your attention to some of the findings in Cycle Toronto's Pathway to Mobility project, connecting older adults to active transportation in Toronto, and to ask that you adopt the recommendation outlined in the report. To include cycling as a policy lever within the Toronto Public Health Strategic Plan 2024-2028 to promote health and well-being across the lifespan. The benefits of cycling for older adults 65 plus are well documented, particularly related to positive mental and physical outcomes. Studies have shown that older adults who bike tend to rank significantly higher in balance metrics compared to those who do not. Older adults want to bike, but need resources and support as much as a safe infrastructure. The need for safe cycling infrastructure is integral to getting more people to bike, but investing in building a culture of cycling is equally important. As I mentioned regarding the newly implemented Huntingwood bike lanes, education and support is needed to connect people to riding on them. E-bikes and adaptive bike styles are a game changer for improving mobility options and mitigating physical limitations like balance and mobility issues. During the Pathways to Mobility workshops, I remember the elation of an 81-year-old when she was able to ride an electric tricycle. Toronto Public Health has a role in advocating for connecting the NORCs that we mentioned to cycling programs by leveraging community organizations and groups. Connecting more older adults to cycling, whether it be for recreation, fitness, transportation, or social activities, will continue in reducing the burden of chronic diseases across the lifespan, will contribute to supporting healthy, age-friendly communities, increase access to underserved populations, as well as achieve Vision Zero through advocating for healthier built environments. Lastly, language matters. Most of my peers and I don't see ourselves as seniors. We're healthy, older adults that are maintaining our independence and freedom of mobility. Please consider advocating for the development and promotion of senior-focused cycling programs and creating connections among the NORCs to the priority actions that support priority action number 2, promote health and well-being across the lifespan. Thank you very much for your time.
Thank you. Right on time. Any questions for the deputy? Seeing none. Thank you so much, Rhoda, for coming in today. And again, 75 years old. Up next is Mary Bernadette Farley.
Hello, Chair Moyes and members of the Board of Health. My name is Mary Bernadette Farley. I live in the ward of Parkdale High Park. I'm presently 66 years of age. I've been biking off and on as my primary form of transportation since the early 1980s, when it wasn't so safe. I've been hit by a car twice, once running, once on my bike. And it wasn't my fault, it was completely the car's fault. I have arthritis, and exercise is supposed to help keep me mobile, and I bike pretty well every day. I rode here on an e-trike. I switched to an e-trike the last week of December in 2023 because I'd had an accident riding my two-wheel bike on the black ice on a side road. In my neighborhood, there weren't yet protected bike lanes. And I'm very thankful of the protected bike lanes now and fearful that they're going to be taken away. I'm here to support your work on the public health strategic plan and to advocate for the development of promotion of elder-focused cycling programs and creating connections among NORCs, not just in buildings, but I would like to see it also, if it isn't 30% elders in your particular neighborhood, that you could join with a building. I feel that Toronto can become a better city for cycling for all, in particular for elders, through a mix of infrastructure, policy changes, cultural shifts, and education, and particularly by direct routes, because we're seniors. We're getting older. It's more confusing to go on the side streets, for one, because there's not direct routes. They're often broken up. You can't have your phone and follow the directions. It's too small for us to see. And it's unsafe using it that way. And also, I would like to see that there weren't just painted bike lanes. I live near Jane and Dundas West, and we have a painted bike lane that goes down towards Bloor, stops at Annette. It's great to have it. It's only on one side of the street too, only going down, not coming back up. And then you have to cut over and go onto a side street. Fine in the summer months when there's no snow, but not doable in the winter, and that's when I had the accident. And then also, the side streets aren't cleared of snow very readily, and the bike lane on Jane Street isn't cleared away. The bike lane on Annette Street isn't cleared away in the winter either. The bike lane along Bloor Street that is protected seems to be cleared fairly frequently. What else? Sorry. Also, riding on side streets I find unsafe at nighttime, and during the winter months, nighttime comes pretty early, before 4 o'clock in sometimes, and I ride 12 months of the year. And many people now are becoming more likely to ride 12 months of the year. And some people, even in Montreal, where the winters are even more vicious, ride 12 months of the year. So we should be able to do it here. I think also if we could have better traffic signs on every block that are larger, that we can see. Also workshops, cycling classes like they mentioned before, perhaps encouraging us to take up bike riding with subsidies, tax breaks for
Final thoughts, sorry.
e-bikes.
Time.
For us elders, pedaling on an e-bike, it's less strain. For us arthritic people, those people lacking.
I'm at
Good
your
knees.
time. Thank you. Thank you.
Oh, I'm out of time, I'm so
Yeah.
sorry.
Any questions for the deputant? Seeing none. Thank you for coming in today. Much appreciated. Juno Stewart. Juno Stewart. Okay. Marvin McCarrig. Online.
Hi, I'm here.
Yeah, go ahead. 5 minutes, Marvin.
Thank you. Good morning. My name is Dr. Marvin McCarrig, and I am a health promoter at Access Alliance, a community health center, and our focus is to provide services to improve the health of newcomers. And this means we work in communities most affected by systemic barriers at our 3 locations in our city. I'm here to support and speak on the Public Health Strategic Plan. We support the plan because of its potential to make Toronto healthier and more equitable. We would like to highlight and draw your attention to some of the findings in Cycle Toronto's Pathways to Mobility project, which work to connect older adults and active transportation in Scarborough, where I work, and to ask that you consider a recommendation of the report. Specifically, we need more cycling and walking within the Toronto Public Health Strategic Plan 2024-2028, and to promote health and well-being by advocating for development and promotion of senior-focused cycling programs and creating connections among naturally occurring retirement communities, or NORCs, which is kind of, I've never liked that name, NORC. The benefit of cycling for older adults are well understood in this year in 2025. We now know that it's very closely associated with positive mental and physical health outcomes. But despite these benefits, and there are so many benefits, older adults face very real physical and imagined barriers that limit their ability to either try biking or to bike more often. This project focused not just on the barriers, but also identified ways to remove the barriers and connect more people in Scarborough. Access to active transportation for older adults must be included in the strategic plan. Last year, our health centers, we served over 250 newcomer adults, older adults, and seniors in our fitness and recreation programs. These participants come to increase their sense of belonging in the community, participate in activities that nourish their mental and physical health, and connect with the knowledge and services that they all need to age in place and stay independent. So simply put, seniors who are independent, who are aging in place, and who are connected with their community, they have better outcomes. A common complaint from our seniors revolves around the cost and safety and transit options. This project, we saw older adults in our program inspired by the prospect of navigating their communities independently with different cycling options. Cycling can provide seniors with a more engaging form of physical activity and dramatically increases the radius which they can travel easily within their community. However, these benefits will be greatly facilitated via the expansion of our cycling network plan. Concern for personal safety when riding or walking is in our city is the main barrier to participants. I know this firsthand. I speak to thousands of Scarborough residents, and personal safety is what they're very worried about. Toronto Public Health has a role in advocating for connecting our NORCs to cycling programs by connecting more adults to cycling, whether it be for recreation, fitness, transportation, social services. It has the potential to reduce the burden of chronic diseases, contribute to supporting a healthy, age-friendly communities, increase access to our neighborhood and the services that we provide, and it'll help us get to our Vision Zero goals. For these reasons, we hope the Board of Health considers developing and promoting more senior-focused cycling programs and create connections among NORCs across Toronto. Thank you for your time. I can answer any questions if you have any.
Thank you very much. Any questions to the deputy? Seeing none. Thank you for coming in today. Next up, thank you. Next up is Karen Ruckus. You here, Karen? Online? Okay.
A second. Can you hear me? Can you hear me?
We can, yeah.
Okay.
5 minutes, go ahead.
Thank you so much. Thank you for the opportunity to present today. and to welcome Dr. Lamptey to the Toronto Board of Health. I'd like to address Toronto's public health strategic plan around the mRNA vaccine platform. A recent global news story from July 2nd highlighted a young mother of 2 whose healthy 45-year-old husband developed a cardiac condition after his vaccine in May of 2021 and later died from myocarditis, a reportedly rare and mild COVID-19 vaccine side effect. She hesitated to share her story, fearing being labeled an anti-vaxxer, the pejorative term used by public health officials and media for those who did their own research and declined the vaccine. I've not met one person who says they wish they'd taken that vaccine, but I've met so many who wish they'd never taken it. By April 2021, it was well established that myocarditis was one of the serious side effects of the vaccine, which can be life-threatening. There are now several jurisdictions around the world limiting the use of these mRNA vaccines or banning them entirely. Recently, the FDA and CDC announced that they would no longer support these vaccines for healthy pregnant women or healthy children. Yet in Canada, we're still administering them. What studies did the FDA and CDC rely upon to arrive at these conclusions? We should know that. Why hasn't Toronto Public Health or Health Canada followed the FDA's lead like we did during the pandemic? Global News went on to say that there are 11,702 reports of serious adverse events following COVID immunization. They're called AFI reports. And as of December 3rd, 2023, now 2023, Health Canada received 488 reports of deaths. These numbers are vastly underreported for a variety of reasons, which I'll share with you. First, Canadian physicians were strongly influenced by the media, Health Canada, and PHAC, believing that the vaccines were safe. So they did not link a heart attack or stroke or seizures or turbo cancers or even death to the COVID-19 vaccines, even in spite of the proximity of that new disorder or death following injection. In fact, Mrs. Carol Pierce died in a Shoppers Drug Mart in Saskatoon in under 15 minutes after the shot, and her daughter was told she died of natural causes. There are now 17 mechanisms of action alone that are causally linked to cancer development post-mRNA injection, and that should scare all of us in that room. Number 2, secondly, most doctors were and still are unaware of a vaccine injury reporting system. My own husband had to inform his physician following his own vaccine injury that there was a reporting system. These vaccine injury reports forms are onerous and physicians are not paid to prepare them. Third, a physician is actually flagged if he or she sends in too many vaccine injury reports, and then they're reported to their regulatory college where the physician is disciplined and often their license to practice is suspended. This intimidation of doctors has caused many doctors to only whisper about vaccine injuries, but not report them. Fourth, the AFI form is submitted first from the doctor to Toronto Public Health, and then it goes to Public Health Ontario before it gets to Health Canada. Okay. However, these reports can be declined at any entry point. So here are the Toronto Board of Health AFI reports as of May 29th, 2024, received through a Freedom of Information request. So the total number of reports that were submitted were 3,835. The total number accepted, 2,699. And the total number rejected that did not meet case definition of an AFI, so remember that, case definition, was 1,136, or a 30% rejection rate of these reports. So now ask yourself, how do these case definitions of AFIs defined? Well, they're defined through what's called a Brighton collaboration. And when you ask AI, who are the public and private partnerships involved in the Brighton collaboration, they mention 6 organizations, 4 of which have moderate to high conflicts of interest with the pharmaceutical industry and 2 with low risk. But this Brighton collaboration includes vaccine manufacturers in its working and reference groups. However, according to AI, quote, this introduces a direct conflict of interest as manufacturers have a financial interest in minimizing adverse events reports or shaping definitions.
Your final thoughts, please.
Anyways, what can the board do? The board, like other boards in Australia, can actually ban these vaccines.
Your time, sorry.
Thank you so much. Thank you so much.
Any questions for the deputant? Seeing none, thank you. Pia Berger, are you here online?
Hi there. Yes, I'm here. Sorry.
Okay, 5 minutes, go ahead.
I just want to see if I can turn on my camera. Oh, there we go. Okay. Okay, so hopefully you can hear and see me. Good morning, everyone. Oh, looks like I'm fuzzy. Before I start, I just wanted to say that I really applaud all the efforts made by this board and Toronto Public Health to promote vaccinations. I appreciate that they are a very important part of maintaining public health. And, I thought it was great when the City of Toronto held vaccination clinics specifically for people who were disabled. That was really important to hold those specific clinics because it made access for disabled individuals much easier. And I'd love to see those come back as well as somebody living with somebody else who is disabled. But I'm here to speak on a related issue. I've taken the time to go through TPH's strategic plan, and there's a lot of really good stuff in there, so thank you for that. However, what I don't see specifically are the words airborne transmission of disease. I also could not find a single mention of clean indoor air, and as we're already over 5 years into the COVID-19 pandemic, I do think it was a major oversight to have left that specific language out. Equitable access to clean indoor air is an accessibility issue. Whether we wish to acknowledge it or not, immunocompromised people are disabled, and they should be able to live in a first-class city in which just entering a public space should not put them at undue risk. Failure to take active and ongoing measures to clean indoor air means we are also failing some of the most medically at-risk people in our city. In reality, though, cleaning the air benefits all of us. We all suffer from the effects of climate change, such as extreme heat and wildfire smoke. If the children of this city cannot always go outside to play because of things like extreme heat and wildfire smoke, then we certainly owe it to them to make their indoor environments as safe and healthy as possible. Toronto should not be a city where growing up involves getting repeatedly infected with serious airborne diseases such as COVID-19. If we truly want to promote the health and well-being of people across their lifespans, we need to start off right by prioritizing clean indoor air for the youngest members of our city. They are our future, and they are the ones who will be looking after us as we age. If we truly wish to advocate to advance health equity, then we need to provide the most at-risk communities, and really all communities, with resources to support their overall health. Again, we need to be having those conversations about all the benefits that come with clean indoor air, as well as how to achieve it. Finally, excuse me, children and families also deserve to have all the tools and knowledge they need so that they can make healthier choices for themselves. This is why today I am calling on you to run a robust public education program about the dangers of airborne diseases and air pollution. And please run this campaign before the start of this school year. We need to give families adequate time to plan ahead. Let's make this September truly a safer September. Thank you.
Thank you. Any questions for the deputant? Seeing none. Thank you so much for coming in today. Next up is Gloria Briston. Okay. Gloria?
Am I unmuted? Can you hear me?
Yes, we can. 5 minutes. Go ahead.
Sorry, I'm just going to see if I can share my video. Oh, I think you can see me. Thank you for the opportunity to speak today. My name is Gloria Britstone. I live and work in Toronto and serve on the governance committee of Can Connect 19, a national volunteer-led initiative supporting Canadians seriously injured by the COVID-19 vaccine. I'm here to speak to agenda item HL 26.2, Toronto Public Health's 2024-2028 strategic plan and your commitment to rebuild public trust enhance transparency, and support communities failed by our health system. For thousands of Canadians harmed by their COVID-19 vaccine, the trust is already broken. What we do now will determine whether it can ever be restored. This is a failed promise. In December 2020, the federal government announced the Vaccine Injury Support Program, stating it would ensure support for those suffering rare but serious injuries. As of December 2024, 3,060 claims were filed, 209 approved, 16.5 million paid out, 33.7 spent, 2/3 of its budget on Auxero, the private firm managing it, 328 appeals processed, and only 10 approved. This is not support. It is a barrier course designed to discourage and delay. In July 2025, Global News investigation uncovered poor planning, unqualified leadership, and serious concerns about how Auxero was selected. The federal government knowingly handed the contract to a firm that turns out was unfit for the job and is yet to address the consequences. There are real lives, real suffering, and stories that are being ignored. Stefan, 21 at the time of his vaccine, which he received in May and June of 2021, shortly after he developed persistent cough, night sweats, weight loss, vision, swollen feet, was denied in-person care for months because he was coughing. By December, he was hospitalized in full-blown cytokine storm and was diagnosed with CML plus PH. His father filed a VIS claim in October 2023. They submitted full documentation, no response. Called, no case number, resubmitted medical, new caseworker was assigned, more info required, then delays. In February of 2025, his claim was denied. They cited that the only trigger for CML is high doses of radiation. Was told symptoms didn't appear till December, but there's records of appointments July, August, September. They ignored evidence of doctor visits, earlier symptoms, and seemed to only focus on his first dose, and he was injured on his second. The family appealed, their caseworker was unreachable, the phone number disconnected. They're now on to a third caseworker in the appeal process, but they're still uncertain whether their case will truly be reviewed. Meanwhile, Stefan's medication costs $2,200 a month, and he has lost insurance after he graduated school. Suppression and disbelief. In May 2021, ER doctor Patrick Phillips raised concerns about adverse event suppression. Dr. Byron Viral, a vaccinologist volunteering with the Canadian COVID Care Alliance, shared biodistribution data obtained via Freedom of Information from the Japanese government, and he was swiftly silenced. And even in 2025, dedicated doctors like Dr. Kushka are being suspended for advocating for their patients. My gosh, by late 2021, frontline doctors were already describing no mandate to report injuries, stonewalling by Health Canada, medical gaslighting of their injured patients. And by the end of 2024, Health Canada had already reported 11,702 serious adverse events. Where is the support? Can Connect 19 is trying to fill that void. That is why we were created. We're a community-led, grassroots organization, exactly the kind of partner your strategic plan calls for. We were born out of the 2022 citizen hearings held in Toronto, where we built a national network offering mental health and peer support, functional and naturopathic care, expert-led forums, a secure online space for the injured. We do what this should have done, but we are all volunteers. This is not and should not be our job. Eligibility, virtually unreachable. To qualify, your injury must be defined as serious or permanent, requiring hospitalization or resulting in death or disability. This excludes many with debilitating, chronic, progressive, and invisible conditions. Many are excluded not because they aren't suffering, but because they are still alive. What can Toronto do? You can apply HL 26.2. Your strategic plan promises strengthening trust, partnering with affected communities, enhancing accountability, and reducing health inequalities. This is your chance to make it real. I urge the board to acknowledge vaccine injury as a public health issue, consult directly with community groups like Can Connect 19, support education and awareness, advocate federally, and provide local and mental health for vaccine injured.
Any questions for the deputant? Seeing none, thank you for coming in today. We're going to hold down this item because we have an 11 a.m. timed item, which is HL 26.1. So I'm going to read the closed session script. Directors, we have an item that requires a closed session. I will move a motion to the board to go into closed session on item 26.1. I'll ask the board secretary to display the motion, which I will read out loud. My screen's not working, so I'll have to use yours. That the Board of Health recess its public session to meet in closed session to consider HL 26.1, appointment of medical officer of health, as it pertains to personal matters pertaining to the appointment of medical officer of health. All those in favor? Opposed? Carried. I will ask the board secretary to close the meeting to members of the public and to only provide access to directors and appropriate staff for the closed session portion for this meeting. In addition, the YouTube live stream will be suspended until the closed session is over. Directors, I would also remind you to arrange your surroundings so that no other person observes any part of the closed session debate. Okay, we do have a speaker on item 1. Daniel Freiheit, 5 minutes.
Good to see everyone in person. It's a lot more three-dimensional. And now, at least the two-dimensional version. I do a lot of advocacy on Twitter under my handle, Lion Advocacy. I started posting because of, to raise awareness about various issues relating to the vaccine mandates for COVID. I saw recently the Global News issued a pretty sophisticated report on the Vaccine Injury Support Program.
Are you speaking
and
to
I'm
item
speaking,
1?
and I'm good. Yeah, I'm going to bring this into, tie it into the role and what this board needs to take into consideration when it's deciding on who it's choosing as the next Chief Medical Officer of Health. I was disappointed that it went in, that it's so confidential that the curriculum vitae is not available to the public yet, and that the public is really not involved in the appointment of the Medical Officer of Health. I did do a brief survey of other jurisdictions and see that this is not uncommon. However, given the past 5 years and what I've learned about this role of this officer and the power, public and private, of this officer, public doesn't know what the Chief Medical Officer of Health can and has done in relation to COVID, something that affected the public greatly. And so to have it go behind closed doors, we don't know where this individual is coming from, what companies this person has worked for, what conflicts there may be. We assume, we trust the board to do its due diligence and to make sure that conflicts, there are no conflicts, and that the next Chief Medical Officer of Health has the courage to address some of the significant issues that are now coming to the fore. And I tie that back to the Global News article, the Vaccine Injury Support Program. These injuries were known by the board. They were known by the Chief Medical Officer of Health. And they will be known to the next Chief Medical Officer of Health. These reports are now coming out in great number and in great detail. So the question is, what can this board do now? What kind of courage can this board muster? A lot of us have had enough of this lack of transparency, the concealing, the cover-ups. It's enough. I'm one of the few private accounts that was reposted by a public commissioner. Not going to give the details, but my views and my opinions are not coming from left field. Okay, I've had influence behind the scenes, changing some of the public statements of some Alberta Health Services and some of these other seemingly insignificant Toronto public health. I think the Toronto District School Board also changed their messaging about the safe and effective when they were trying to get the kids to take the vaccine. But if this board doesn't acknowledge the errors and what it needs to do going forward to fix things, you could talk all you want. Like I sit now and I listen, and it's hard to describe the feeling, but it feels like there's a veneer, a facade. It's all disingenuous if you don't do one simple thing: acknowledge that there were mistakes, acknowledge that not everything was done correctly, and apologize. Actually apologize. This board, this city, I spoke to this board from November 2022. I said, why are you still requiring city employees to get vaccinated? It was known the provincial and federal medical officers of health, as in early 2022, said the thing's not working like we planned, ease up on the mandates. Cities like Toronto, then in November they eventually took it off. City of Hamilton, they still kept it going. Why? Because their Chief Medical Officer of Health was busy with other things up until March or April or the spring. Eventually there was enough pressure for that Chief Medical Officer of Health to say, okay, maybe I should come back and advise the board to take their mandates off.
Point of order, Mr. Chairman.
Sorry. So people need to understand that this...
Hold your thoughts. Go ahead.
Say it again?
Mr. Chair, allowing the deputy to use that kind of language and those kinds of accusations and those kinds of words just simply encourages really bad behavior. It's like a norm that you're able to just point the finger and say that people are lying or people are hiding things and they're being mischievous. You know what? It's inappropriate, and I think you should just sort of stop that, right?
I never said
Because
anybody lied.
just what it says is that he can do it, and the next guy can do it, and the next guy can do it, and then you and I.
Yes, Councillor Pertsa, yes.
Sorry, what
You
exactly is
you-
inappropriate?
You said cover up, and that is inappropriate, and I actually agree with Councillor Pertsa.
And that, the other, like, come on, seriously?
Yes.
Sorry, do I get added to the time now just to
You
address
have-
that? What the cover up?
15 seconds.
If you got something you can point to directly, like, bring it forward, right? But don't just use innuendo, right?
Okay, in terms of substantiating any claims that I'm making today, I will review the video of this to substantiate, and I will make it public, or I will publish it, and if that's
You
okay
said
with the
you
board.
used the term cover up, and that wasn't appropriate. So you have.
I apologize
15
if that
seconds.
requires clarification. I will clarify what I do mean by cover up. To the point is, this board and the current chief medical officer of health and the next one need to apologize. There were people that were injured from this thing. They're getting swept aside. They're not getting the attention they need. And,
Thank you. Any questions for the deputy? Seeing none. Okay, on the item, any public questions from directors? Any speakers on the item? Okay, go ahead. Okay, we do have a recommendation. The clerk could have some posts. So just to state that we did go through a substantive search. And on the search committee, we had myself, Vice Chair Bravo, Director Zhao, Director Chandrabalan, the mayor. Who am I missing? That's everybody? Yes, so those were the committee members. And we did a robust search and came up with one candidate. And thank you to all those who participated. Yeah, those are my thoughts. I can't speak too much about this because it's still in the process. Councilor Bravo, Vice Chair Bravo, you have any comments? Oh, I moved it. Yeah, go ahead and speak.
I want to echo the words of the chair. It's been a robust process with broad participation. The board members that participated were engaged and contributed, and there was a very thoughtful series of discussions about the important pivot that's being made now after a period of incredible stress on Toronto public health to come out of the pandemic and face the many new and continuing and emerging challenges that affect people of the city at a population level, and to continue to promote in a very robust way equitable health outcomes that make us all better.
Okay, thank you, Councilor Bravo. Any other speakers on the item? Seeing none, okay. All those in favor? Opposed, carried. Okay, we completed one item today. That's good. Let's go back to item number 2. We'll resume the speakers list. We have 4 speakers on here. Mareko Ude, are you here? Okay, go ahead.
Okay, so back to the strategic plan. I would like to address priority 1A of the strategic plan, which says, prepare for and respond to outbreaks and public health emergencies informed by the best evidence and lessons learned from previous responses. I agree with this statement, but I'm concerned about what Toronto Public Health will consider as best evidence and lessons learned. Because the COVID-19 mRNA vaccines, which I and many others consider unacceptably harmful and questionably effective, continue to be offered. I would like to use my time today to quickly introduce two excellent documents prepared by Canadian scientists that I believe should be included in your review of best evidence. The first one is an article in the Journal of American Physicians and Surgeons, written by mostly Canadian scientists, about the Pfizer vaccine. It's called Pfizer-BioNTech's COVID-19 mod mRNA vaccines, a dangerous genetic mechanism of action released before sufficient preclinical testing. It goes over the Pfizer vaccine and the issues that have been identified about these vaccines, including the adverse events, poor clinical trials, and inefficacy. The paper concludes that the Pfizer vaccines should be removed from the market and their use in humans stopped. And the second document is a Canadian open letter by Canadian scientists and clinicians calling for a halt to the vaccines. This one is dated March 31st, 2025. And it cites issues such as DNA contamination, SV40 DNA sequence in the Pfizer vaccines, batch inconsistencies, and ribosomal frame shifting and shift to IgG4 antibodies. I can't go into each of these in detail in my 5 minutes, but I've attached both of these documents to my deputation letter, which will be posted online for anyone to see. And I picked these two documents because they're good summary documents. Some scientific papers are very detailed and go into like one experiment, but this is a summary document, and the call to halt letter is also a summary document. So two of them together cover most of the issues you need to know about these vaccines, and they're very well referenced and very high quality. As for lessons learned, I believe the full extent of vaccine injuries needs to be acknowledged. Recently, on July 2nd, just a week or less than a week ago, the Global News came out with an investigative report called Immunized, Injured, Incensed. And it says that the people that they highlight in the article, including a 45-year-old man that died from the vaccine, are some of the thousands of seriously vaccine-injured Canadians. The number is likely many times higher due to underreporting. If we turn a blind eye and don't look into this properly to the full extent, then the future will be more of the same. When I did my research for my PhD, it was on resilience and how to build a resilient city. And I looked into strategies for how to do that. And one of them is to have good working negative feedback mechanisms. And the best way to describe this is that, you know, if you touch a hot oven, then you're gonna feel pain. Pain is a negative feedback mechanism. And so, you know, pain, it can be painful, but that's how we know we're doing something wrong or something needs to be corrected. And if that mechanism is not working, as I don't feel it's working now, then you're not gonna get that message and you're gonna keep doing what you're doing and it's gonna cause further harm. So I really think we need to look into this deeply and fully investigate it and learn from it. And then we can say that we have truly considered the lessons learned in a proper way. Thank you.
Thank you. Any questions for the deputant? Seeing none. Thank you for coming in today. Next up is Teresa Dinning. You have 5 minutes. Go ahead.
Thank you. Good morning. There has been some positive progress for those of us who have been raising concerns during the strategic plan development process and directly to the board about vaccine safety and the government's response to emergencies. In June 2025, the leadership at Health and Human Services in the United States announced that until Gavi, the Global Vaccine Alliance, treats vaccine safety as a patient issue and not a public relations problem, the U.S. will no longer provide Gavi with $8 billion in funding. This announcement indicated that during COVID-19, amongst other issues, Gavi partnered with the World Health Organization to recommend best practices for social media companies to silence dissenting views and to stifle free speech and legitimate questions. Whereas Gavi should be considering the best science available, even when that science contradicts established paradigms. In Canada, the newly elected MP, Matt Strauss, recently gave his maiden speech in the House of Commons. He spoke about what he described as the government's abuses during the COVID-19 pandemic, the lockdowns, separating families, $600 billion in spending, doubling the national debt, all this in the name of crisis management. He said physicians, professors, journalists who spoke out against these abuses were hunted down and had their licenses and jobs threatened. He knew this because it happened to him. Dr. Strauss said the government claimed upon themselves the power to censor the news and violate free speech in the name of fighting misinformation, while they themselves promoted misinformation. When ordinary, everyday Canadians tried to raise issues concerning their Charter of Rights to bodily autonomy, assembly, and free movement being violated, all members of the Liberal caucus voted to trample their rights further by imposing the Emergency Measures Act. They trampled on Canadians' Charter of Rights and then they laughed about it, he said. If we cannot speak truth to their power, everything will break. Matt Strauss said this is why he's in Ottawa. He refuses to be a cog in their broken machine. Finally, an MP in Ottawa who has the integrity and the courage to speak out. Another helpful development, albeit upsetting to watch, was the recent Global News report that finally raises concerns about the unexpected high number of serious vaccine injuries and the challenges Canadians are experiencing getting support through the government vaccine injury program. As you work together with the Ministry of Health to understand the reasons for vaccine hesitancy and misinformation, I recommend that the Board of Health hear directly from a panel of expert doctors, scientists, healthcare practitioners, and vaccine injured who have raised concerns during the last 6 years and longer about vaccine safety. No one should be accused of misinformation without a public debate.
Okay, thank you. Any questions for the Deputy? Seeing none. Skylar Hill Jackson, are you here? Yep. No applause, please.
Overhead, please. Stop the clock till I have the overhead, please.
Can you start while they're figuring that out? We're short on time.
I want to make sure it's positioned correctly. I need to. See, it's like it's wrong. Why isn't it 8 by 10? Okay, thank you. Before I start, I'll just mention I'm 76 years old and I'm still riding my bike around the bike lanes in downtown Toronto.
Wonderful.
And so is my husband, who's 78. He went on the High Park ride that started yesterday. Okay. First, I would like to answer the 2 questions the Toronto Board of Health Chair, Chris Moyes, asked at the end of my June Toronto Board of Health deputation. How many people died of the Spanish flu? The 1918 to 1920 Spanish flu caused between 50 and 100 million deaths worldwide. An estimated 50,000 people died in Canada, mostly young adults between the ages of 20 and 40. Worldwide, of the 500 million people who contracted the virus, there was a mortality rate of between 10 and 20%. The main question to ask is, what were the sanitary, food insecurity, and crowded living conditions in 1918? In 1918, bacterial pneumonia was the leading cause of death. Today, pneumonia is a common illness and anyone can get it. Influenza often leads to bacterial or viral pneumonia, and in Canada, approximately 6,000 people die of pneumonia each year. The second question was, what about polio? Polio emerged suddenly in 1912 due primarily to the widespread use of toxic pesticides using copper, arsenic, lead, and DDT, and also due to various types of poisoning, including bacterial contamination, insecticide spraying, and contamination of water and food by toxic chemicals. The risk of contracting wild polio in Canada is virtually zero. The polio vaccine does not prevent infection or transmission. The safety of the live or dead poliovirus vaccine has not been proven against a true placebo. We need to do our own research. Is your health and the health of your child worth a few hours of research? Vaccines are complex biochemical substances that, by definition, are drugs. Once injected, these vaccines can cross the blood-brain barrier and cannot be deactivated or removed. Thanks to the experimental COVID-19 vaccines and booster recommendations, Canadians are questioning the safety and efficacy of all vaccines. In 1983, there were 23 doses of 7 vaccines, and in 2025, there are 90 doses of 19 vaccines. Have vaccines made our children healthier? Toronto schools are full of children suffering from a variety of chronic illnesses. More than 72,000 children are registered in the Ontario Autism Program. Who is going to look after these children when they become adults and their parents are dead? Should this be in the Toronto Public Health Strategic Plan for 2024-2028? Should we worry about vaccine roulette? Will my new grandbaby have a lifelong chronic illness or autism? Today, every pregnant woman has a healthcare provider encouraging 7 or more vaccines in pregnancy. But please don't smoke or drink alcohol, because that may cross the growing baby's blood-brain barrier and damage the baby's brain. Remember, there are no placebo-controlled clinical trials to confirm the safety of vaccination of pregnant women for their unborn baby. For the first time in history, children are sicker than the generation before them. Again, the effects of vaccination are irreversible. One mistake early on, and the brain and the body of your baby or your child may be forever changed. Vaccination is a medical procedure which is designed to permanently alter our immune response. Public health has shifted the human population to dependency on vaccine-induced immunity. We have developed a world that is dependent on vaccinations. We no longer trust our own natural immunity. Educate before you vaccinate. How many is too many? What are the risks? What are we risking by not knowing? We need to do our own research to protect ourselves and our families.
You're at time.
Warning, if you don't think for yourself, someone will do it for you.
Thank you. Any questions for the deputant? Please, no applauses. Saying no for the questions. Zoe Michael? Zoe Michael?
It's all right, it's a Swiss name, so it's not the easiest to pronounce. Hello, everyone. My name is Zoe. I'm 18 years old, so I just graduated last year. And I would like to continue on Skylar's talk about actually vaccinations in schools. So many parents know that in grade 7 and 8, students are given a list of required vaccines to attend school or they risk suspension. So at the beginning of each year, students get a form that they have to take home to their parents to sign regarding these vaccine clinics. In my case, there was no date ever given for when the vaccine clinic would show up, so it was always a surprise. In my case, I would run down to the office to phone my mom and tell her that they were vaccinated that day because I didn't have a phone, and I was just sometimes worried because even though I had an exemption, I've had an exemption since I was 3 years old, they can be quite convincing at that time. But I've grown in confidence, so I knew like nobody would be able to coerce me into doing something I wouldn't want to do, so I still went with my friends. In the cafeteria where they held that vaccine clinic, there were mats on the floor for students to recover for 20 minutes after their injection. And I saw many of my friends feeling extremely ill and even faint following especially the HPV vaccine. So personally, I was quite happy to be exempt. I want to add that in 2014, the World Health Organization announced their new implied consent policy in a paper entitled Considerations Regarding Consent, Vaccinating Children and Adolescents Between 6 and 17 Years Old. Quote, the physical presence of the child or adolescents with or without an accompanying adult or parent at the vaccination session is considered to imply consent. This means that a child sent to school on the day of a school-based vaccine clinic is now consenting by implication, end quote. Today, many parents do not send their children to school on school vaccine clinic day, or in my case, would pull them out, in case of peer pressure or adult coercion. As there is also, I want to add, there's a big stigma for unvaccinated kids, and it's actually not a great place to be when you're that age. So how many Toronto parents are aware of the mature minor doctrine added to provincial health acts that enables minor children under age 18 to consent to medical treatments such as abortion services, birth control, and vaccination without parental knowledge or consent? So apparently the WHO feels children 6 to 17 years old are able to give consent for medical treatments without parental knowledge or consent. Like, do board members not find this shocking? I mean, I certainly do.
So remain on the topic at hand here.
Yeah, I just...
You are way off topic, but continue.
I just wanted to add that just for when you guys are going to do your strategic plan in 2024 and 2025, just to make sure that you guys do include, well, the whole vaccine clinic thing is just a big thing for me, and I just wanted to say that it was quite unsanitary the way it was done at my school as well, saying that it was in the cafeteria where we were going to eat hours after, and then there should be not be just this push for stigma that other people, you know, put on the kids to almost coerce them into doing something that they would not want to. So I'm sorry if I was a bit off topic, but I just wanted to add that just so that when you guys are doing your plan, guys take that into consideration, that not all students are for that. But anyways.
Okay, thank you.
No, but still thank you for letting me speak.
No worries.
Have a nice day, you guys.
Any questions for Deputy? Seeing none, thank you. And that is the last of the list. I'll take it in-house to directors. Any questions for staff? Councillor Chang? Sorry.
Thank you. Thank you for this update on the strategic plan. I'm wondering which category or where would I find more information about work being done on early, I guess, maternal health and early parenthood, because these are programs that I saw were being run by Toronto Public Health when I was starting out as a parent, and I've noticed that they've been scaled back significantly. So I'm just wondering, where do those types of programs fall in the strategic plan? And is there a consideration of adding some of these back in consideration of the impacts of adverse childhood events that can happen? And so when we support parenthood earlier on, I think there are ways that we can do upstream investments.
To the chair, I'll begin, and then I'll invite our Director of Community Health and Wellbeing to add on. So under Party 2, promote health and well-being across the lifespan, you can see that the second action there is to actually increase access to healthy growth and development services for underserved populations. So that speaks directly to your point around programs in prenatal, perinatal, postpartum, and early childhood public health actions. As we said in the presentation, sometimes that involves partnerships with community agencies like community health centers, for example, ancestral health midwives to offer increased breastfeeding clinic access. So my colleague here, Joanne Vigliano-Scott, can add more to that. And we do anticipate that we'll be bringing to the Board of Health a more fulsome report about our work in this area.
Thank you for your question. Through you, Mr. Chair. We have a full slate of what we call healthy growth and development programs. So in addition to our breastfeeding clinics, which we've expanded to include 2 new ones, extended hours, virtual options, and home visiting as well. We have our Healthy Babies, Healthy Children program, which reaches high-risk moms. We do also receive referrals from hospitals for all new babies that are born, and our Toronto Public Health team reaches out to provide consultation and advice. We're very excited because we have been doing quite a bit of work around adverse childhood experiences, including participating on an initiative with Public Health Ontario and recently released an ACEs framework for which we're looking to implement at the local level, and that was under the leadership of Toronto Public Health as being a co-partner at that table. And we've been meeting with our division partners to start to look at how that resiliency framework can be applied across the City of Toronto. And like Dr. Lamptey said, we're looking forward to bringing a report that provides a more fulsome update on all of our services in this area in the near future.
Thank you. I look forward to understanding further. I think those are so important, and just knowing the significant impact that adverse childhood events has on health outcomes, but also noting that there was a period of time there were parenting classes offered by Toronto Public Health, and I saw that they kind of disappeared, and look forward to seeing what a new pathway will look like and new programs to support early development. Thank you.
Thank you. Any further questions by any of the directors? I'll just ask one. We had a lot of presentations today around seniors and biking and healthy living. What steps have public health taken to maybe make sure seniors are active and healthy?
So to the chair again, I'll begin and invite Director Joanne Vigliano-Scott to add. So under, again, the same Priority 2, promoting health and well-being across the lifespan, you'll see the last action talks about collaborating on strategies like Vision Zero and Safe TO. Vision Zero involves reducing collision-related injuries, including from cycling, to promote the well-being and safety of residents and communities, as well as collaborating on the development of the Toronto Seniors Strategy 3.0 through the Toronto Seniors Accountability Table. So as a partner in collective work across the city to promote health and well-being and reduce injury, there are many actions to not only bring the health information and statistics about where there's higher risk to conversations about physical activity for older adults, but also to contribute to the policies that help build a healthier environment. That includes things like cycling infrastructure, which is actually under the direction of other divisions, but we are involved at the tables where decisions like that are being made. And I would also say that we have a very strong working relationship with the Toronto Senior Services and Long-Term Care Division, and are continually looking to see how we can contribute more services to that population. Joanne, would you like to add anything else?
Yes, thank you. I'll just add that in addition to the evidence and data that we provide to the partnerships and connecting different partners together on some of these important initiatives, we are also partnering with Toronto Senior Services as well as Toronto Seniors Community Housing to implement some health promotion initiatives in Toronto community housing buildings this coming fall. We're set to launch for this fall, where we'll be promoting things like healthy eating, active living, falls prevention, and that's a result of some of the work coming out of Economic and Community Development Committee.
And just to pivot a little bit on the priority number 3, one of the things we're talking about here is our health, our city, more specifically the Heart Hub piece. What are some of the services we're hoping to have within that?
To the chair, are you asking about services within the Heart Hub?
Yes.
So as we presented at the Board of Health last month, it fits within our vision for the ability to provide a comprehensive suite of evidence-based, evidence-informed services to those seeking assistance with substance use challenges. So that includes harm reduction services, access to harm reduction supplies such as naloxone kits and sterile needles, as well as access over time to primary care as that gets built out with our partners, in addition to accessing to treatment, mental health treatment, as well as substance use treatment through our partners in a range of acuity. So as the permanent site gets finalized, that includes outreach and drop-in services right up to potentially inpatient care for those who need it.
And just to touch on Councillor Chang's point around women, in the Heart Hub, are we looking to provide services for women, especially those that are maybe more vulnerable?
So to the chair, I'll start, and then I'll invite our director, Sana Imran, to add on. So one of the guiding principles of the Heart Hub is to be evidence-informed and trauma-informed. And we know that gender-based experiences can be a form of trauma. So that includes training our staff to be able to recognize and refer clients to services that may help them with that. And in addition, looking at the composition of our team so that people can feel safe when they come into the space, as well as our linkages to other partners like the Gerstein Center and others that have specialized services for particular kinds of trauma. Ms. Imran, would you like to add anything?
I think you covered it, Dr. Lamptey. Just to add that we are working with all our partners to identify specialized programs that they may have within their organizations, such as Unity Health, such as our city divisions and other partners, to understand so we can make all those referral pathways very clear as well. So whether it's within the Heart Hub model or with our partner, we can connect clients to what they need.
Thank you. Those are my questions. Any other questions from directors? Seeing none, Dr. Zhao, go ahead.
Yeah, thank you so much for putting together the dashboard. I found it very informative as a way of keeping track of the priorities. Some of the deputants did mention about air quality in schools and in buildings that public health might occupy or that are owned by the City of Toronto. I was wondering under what priority is something like air quality, especially in the context of, for example, schools, or as a result of wildfire smoke, for instance, is that considered in the strategic plan?
So to the chair, I'll begin and then invite any comments from my colleagues, Dr. Shapiro, Dr. Chris from the Health Protection team. So I think under Priority 1, strengthen health protection, disease prevention, and emergency preparedness, wildfire, smoke, and pollutants, whether they're indoor or outdoor, are threats to health that we have a suite of services under the umbrella of health protection to respond to them. So, for example, when we talk about, developing and implementing our climate change surveillance framework, as we're building that out, understanding about the impacts of things like air quality on our health over time as that changes with climate change is one example of a measure there. In our emergency response activities, we are part of the Toronto Emergency Management structure in terms of responding to heat events when air quality might be affected by wildfire smoke, and we do have a wildfire smoke strategy. Many of our works on climate change response as they relate to heat are also potentially protective from outdoor and indoor air pollutants. And then, of course, our work in the respiratory season to inform people about the importance of ventilation as a disease protection measure also can deal with other kinds of indoor air pollutants. Dr. Shapiro or Dr. Chris, anything you'd like to add?
No, I think I'm pretty good. I think we do things like, it's not somewhat, we're piloting cleaner air spaces this year in some of the civic centers in the city of Toronto. And part of that pilot will also involve measurement of the air quality inside and outside those facilities so we can better assess the protection that the cleaner air spaces are providing. So that's one particular initiative that I can think of.
Thank you very much. Any further questions?
Will the measurement of air quality be one of the metrics on the dashboard? I think having that would be really helpful for some of the deputants who brought up that concern today.
So to the chair, I don't believe air quality is currently in our strategic plan dashboard because the actions, as you see here, are a little bit broader than that. But perhaps some of the way that could come through is, for example, when we understand how our measurement in the Clean Spaces Network proceeds, it could potentially be part of the narrative progress report that we'll be bringing to the board once a year. And of course, the strategic plan is not the only way that we report to the board. So in the future, there could be other Board of Health reports on that matter.
Okay, thank you. Seeing no further questions, we can go to speakers now. Speakers? Okay, Councilor Bravo, go ahead. You want to move the
Thank you, Chair. I have a motion, and it's regarding the deputations that have come here today in relation to Toronto's to Cycle Toronto Pathways to Mobility. It's first of all a request to Medical Officer of Health to consider its findings and recommendations of the report as an attachment and as part of the ongoing implementation of the Toronto Public Health Strategic Plan 2024-2028. And secondly, to amend the Toronto Public Health Strategic Plan 2024 to 2028 Action 8 as presented in Attachment 1 to the report by adding the following. So it reads as follows. Collaborate on the development of the Toronto Senior Strategy 3.0 through the Toronto Seniors Accountability Table, including to promote increased access to behaviors and activities that promote health and well-being, such as cycling. I think it's well established and has been reported on by Toronto Public Health, and this board has adopted those findings that cycling and mobility, active mobility, are crucial to population level improvements in health. Maintaining health, connection, community, climate action, these are all things that are tied together. I want to thank Cycle Toronto and the group of active and older adults, seniors that have come together to put together this project and this piece which is really incredible work to show that seniors and older adults, I don't know, there's a bit of a feedback here. Sorry about that. Do want to cycle, that is fostering connection and coming out of communities, that this is absolutely necessary in every part of the city. That it's, to me, it's in part the access to the city, the freedom to be in your city, in your neighborhood, to enjoy it on a level that's much more human, that's much more real, where you can meet someone, get together, notice things that you would never be able to see from a bus or from a car. This is the way that I experience it myself. I think that changing the whole story about who cycles, who wants to cycle, and what cycling does for a person is really part of the work that's been done here. I also I want to echo the words of Councillor Chang around children and youth. This area of work of improving health through the lifespan, of a lot of concerns in terms of children and youth, what we're doing, their outcomes, their mental health situation. And I will say that this activities that we're talking about, community building, relationship building activities, have the incredible advantage that they're cross-generational. When you are able to put people in relationship with each other, there's increased accountability, there's taking responsibility for each other, and the implementation of the strategic plan is very dear to me, having chaired this process, working with public health staff, the members of the committee, the board, and the many, many people that contributed to this plan, more than 1,000 people, more than 1,400 people, so many organizations. It's an exciting plan to look at when public health really works, you don't see its hand. And when it really is preventing harm and promoting healthier outcomes through interventions that make so much sense. We know we're succeeding when there is less inequality in terms of health outcomes, then we know we're really meeting our mission. Thank you, Chair.
Thank you, Councillor Bravo. I too would like to just echo some of the comments by Councillor Bravo. It's only been a year since we've actually had this strategic plan in place. And there are 22 key strategic plans, and as of now, 20 of those are either complete or in progress. That's quite extraordinary. And the work doesn't happen by itself. It takes the dedication of our staff, our public health staff, to make these things happen. They are caring people, they're professionals, who really care about the city and the health of the city. And under the leadership, of our medical office of health, this has really happened. So I just want to say thank you to all those who've actually made this happen. It takes a village for sure. And I lost my train of thought. It happens sometimes. I think I would say it, I have a seniors moment. I'm almost there. But, thank you to all those who contribute to all of this. And I'm really happy to continue to support this initiative. Any other speakers on the item? No? Okay, so we'll move Councillor Bravo's motion first. I'll put it on screen. Okay, all those in favor? Opposed, carried. And what about the original? Okay, that's great. So we've done item 2. I'm actually going to move a motion. Yes, it's wonderful. I'm going to move a motion to extend the meeting to the end. I'll move that motion. Do you have a motion? Okay. We'll try to get through this as quickly as we can. I know that Toronto Police and others have been very patient. All those in favor? Opposed, carried. Okay, so to item 3, 26.3, Toronto Population Health Status Indicators, a tool to advance health equity. And I believe there's Councillor Dr. Lamptey, go ahead.
Good afternoon, and thank you for the chance to present this work to the Board of Health. In 2023, we presented our population health profile to the Board of Health that provided an overview of the health of the city. What it did not provide was more granular data, such as data available at a level below the City of Toronto in terms of geography, or any data on racial or ethnic information. I'm pleased to present a tool that is available to the board and the public that helps us plan programs and services that advance health equity. This tool is a population health status indicator dashboard that I will refer to as FISIES in the presentation. And I'm pleased that we also have our acting manager from the Epidemiology and Data Analytics Unit, Carolyn Lai, who will be showing a short demonstration of this tool. Next slide, please. You just heard about FISIES, and they are one of the key actions to help meet priority 4 of the strategic plan, advocate to advance health equity. Part of our mandated work at Toronto Public Health in the Ontario Public Health Standards is to conduct population health assessments to help us understand the health status of the population and identify inequities between subgroups of the Toronto population. Population health assessments include analyzing and reporting on a series of health indicators across a lifespan and in different areas of health. The FISI dashboard is an interactive tool for sharing these population health level data with TPH program staff, but also with the public and community groups and other health service providers. FISIs are therefore an input into program planning and resource allocation, and for meeting our strategic priority of advancing health equity to meet our mandate. Next slide, please. The FISI dashboard builds on a dashboard that was initially launched in 2019. In 2023, TPH began to do its first major update with a refresh that consisted of updating the geographical boundaries as the city moved from 140 to 158 neighborhoods, and determining an alternative sub-Toronto geography when there was not neighborhood-level reporting available. Reviewing available data and how recent it was, a new design and look to increase accessibility using software, and updating existing indicators with the most recent available data after the pandemic. In addition, many new indicators were added, especially in child and youth health. This new design was developed with many partners, such as collaboration with the Ontario Community Health Profiles Partnership, which hosts the dashboards and also provides complementary data, consultation with TPH programs, city divisions, and community partners, and engagement with equity leaders on how to present data for equity in a meaningful and responsible way. Next slide, please. The new refreshed dashboard was launched in February 2024, and topic areas were updated in 3 phases through February of this year, 2025. We needed to use a phased approach because of the number of indicators, and also to allow time to facilitate additional consultations with equity leaders about how to present socio-demographic data in non-stigmatizing ways. Currently, FISI includes data on 118 indicators across 7 topic areas from various data sources. The identification of these indicators was collaborative, including our TPH epidemiologists, our program areas, and external partners, as I mentioned. Initially, there were over 300 indicators under consideration, and after that process, 118 were selected for this version. Next slide, please. A unique feature of the FISI dashboard is that indicators are analyzed in different ways to allow users to identify, monitor, and respond to health and social inequities that are driven by factors such as systemic discrimination. For all indicators, there is the ability to compare Toronto to the rest of Ontario and the rest of the Greater Toronto Area. If there is historical data available, users can also see changes over time or trends over time. For each indicator, there is as much disaggregated data provided as possible. This includes a breakdown by neighborhood and community cluster, and the ability to display the data on a map. So if you go to the next slide, please, we'll give you an example. Here's an example of an indicator to show you how granular the data could be on the dashboard. This is a map that shows the distribution of low birth weight in Toronto. The more blue the color, the darker the blue, the higher the rate. In this case, it's the rate of low birth weight infants by neighborhood. Next slide, please. Here's another indicator that shows how the data can be displayed at a granular level in terms of racial group. This is a graph showing sense of belonging to local community across ethno-racial identity groups in Toronto. Next slide, please. So I'm very pleased that we have our acting manager here, Carolyn Y., who's going to be showing you a short demonstration of this tool, and we invite you to, following this presentation, have you and your teams interact with it to see the kind of questions that it raises. Over to you, Carolyn.
So thank you very much for the opportunity to present the dashboard on behalf of my team. Almost everybody on the team contributed to this dashboard, and we're really quite proud of the work that we did in this particular refresh. So as you saw on the last slide, we do have a vanity URL for the for our dashboard. It's toronto.ca/phsi. It takes you to this home landing page, which gives you a general description of the dashboard and the types of data that you'll find on the dashboard itself. You click the button and it takes you to the actual landing page. So I'm just gonna move this here. So again, a general description of the dashboard. You'll note that there are 7 icons for the 7 topic areas that are covered, and for each of the topic areas, they're in of itself a mini dashboard, which I'll get to in a minute when I do the demonstration of 2 indicators. I want to note that the real benefit of this dashboard is that it does show health disparities, so those differences in health outcomes between 2 groups. We've been really thoughtful about the process to kind of talk about that the differences are often rooted in social determinants of health and experiences of racism and discrimination. So it's sprinkled throughout the dashboard. They'll have pop-up boxes that talk about why we display geography, for example. We do also provide a list of other sources of population health data, and important to note here is for population health data for Indigenous people in Toronto, we refer to everyone to the Ontario Health Count study from Well Living House. We also avoid duplication. So not everything is on the FISI dashboard. So where there's already a value for an indicator for Toronto where we cannot analyze below sub-Toronto geography or additional demographics, we just refer you to the actual source of that data. And finally, there is an extensive user guide. However, you're free to contact our team and we would get back to you with any questions or training that you have. So I will be demonstrating 2 indicators, mainly because it demonstrates really well the 2 types of data that our team does have access to, and that's health administrative data and survey data. So the first one I'm going to show you is Falls Emergency Department visits for people age 65 and older. So all the dashboards and the indicators are laid out roughly the same way. In this instance, you'll see a general description of the injury dashboard. You'll see that we do, again, list where you'll find additional resources and data. And then you come to the dashboard itself, where you'll have the indicator selection. So here, for this one, I have 2 indicators. I'm going to click the ED visits. It pops up the actual definition of the indicator. So in this case, the number of ED visits or emergency department visits for unintentional fall-related injuries for those 65 years and older per 100,000 population. We give you a top-level highlights, usually about 3 points, if you don't want to read the rest of the dashboard. So again, the rate for Toronto, how do we compare to the rest of Ontario? How do we compare to the rest of the GTA? We tell you if we can see a trend or not, and we tell you if there's any differences by demographics. So again, the overall findings, the Toronto trend, again, you'll see a hover over. Ontario rate, and in this case, we say that the trend at this time is inconclusive. For this particular data, we actually do have a number of years available. And for each data point for each year, if I hover over, you'll see that we give you a rate. Similarly, for the regional comparisons, if you hover over, we'll give you the rate. In this instance, for example, the Ontario excluding Toronto rate, when you hover over, you'll notice under legend it says H, and it says statistically higher than Toronto. So we do the calculation for you. So in this instance, the Ontario rate for those who are 65 years and older and their emergency department visits for unintentional falls is statistically significantly higher than Toronto. Because this is healthcare administration data, we are able to show you very granular neighborhood level data for this indicator. And so similarly, if I click, in this case, it's Bendale South. Again, we give you the rate for Bendale South, and in the legend, we'll tell you, in this case, it's not statistically different than the Toronto rate overall. If you don't know your neighborhood, but you know the neighborhood name, you can scroll down. So for example, here's Cliffcrest, and similarly, it'll pop up the box. And finally, below, we give you a little bit more detail about the demographics. Now, here is a limitation of healthcare administrative data. They typically only collect for age and sex. And so we, again, similarly, if you hover over, you'll see the different rates for age and sex. And we do an area-based analysis on income so that we can look at some income differences for this rate. And so for overall, for this indicator, we saw that the rate was stable pre-pandemic. It's a little bit too early to tell about the trend post-pandemic, but we continue to monitor. There are some differences based on age. As you can see, those who are 75 years and older are more like, have a statistically significant higher than the 65 to 74, and there are differences between male and female as well. In terms of our TPH programs, we continue to use the data to monitor for our own falls prevention data, but I do want to note that we have presented to the Senior Strategy Accountability Table as part of their Senior Strategies 3.0, as well as Parachute Canada, which is a national injury prevention organization who are planning an event for equity-deserving communities later this year. So the next indicator I'd like to just show you is self-rated mental health. So you'll note again that, as I mentioned, the dashboard looks pretty similar to injury, although it gives you now a description of the mental health and substance use dashboard. Again, alternative resources, additional data, and then the indicator selection. I'm going to click self-rated mental health. It pops up the definition. Again, the key highlights about the Toronto rate, whether there's any sort of comparison to Ontario, and whether there are any differences from a demographic perspective. Again, the overall findings, you'll see in this case, we do actually mention that there is a trend of decreasing over time. The regional comparison similar to the 65 years and over. If you just hover, it gives you a little bit of a breakdown. For Ontario, it's not statistically different. And here's where you'll note the first difference. So these data come from the Canadian Community Health Survey, which is a representative sample of Toronto. But it does mean that you don't have enough data to be able to report at a neighborhood level. So for these data, what we've used is the former community clusters that were developed during the COVID-19 response. And for this indicator, you'll note that we even have to combine a couple of the clusters in order to have a reportability at a sub-Toronto level. But similarly, if you click on it, it functions in the same way as the neighborhood level. When you click, it pops up. This is North and South Scarborough. It gives you a rate, and it tells you it's not statistically different from the rest of Toronto. Now, the main advantage of survey data is that there are usually additional demographics that are collected. So again, for this indicator, in addition to gender and age, you'll see that we are able to report on ethno-racial identity, immigration status, sexual orientation, education, and income group. And so for this indicator, as I've noted already, we have seen a decline over time for self-rated mental health. And there are differences, as you can see, for ethno-racial identity, immigration status, and education. As you know, mental health is a priority for Toronto Public Health, but also for other city divisions. And in addition for using this data for our own programming, we have also presented to social development, Safe TO, and community development teams. And finally, just to close off, I want to show you 3 other additional functions for each of the dashboards. So if you scroll to the top, you'll note these 2 buttons. For each dashboard, when you click the download data button, all of the data down for the dashboard, for the entire dashboard, will download into a spreadsheet so you can play around the data if that's something you're interested in doing. We do provide extensive technical notes, so for each indicator, where the data source is, some of the decisions we made during the analyses. And then a fun little kind of tip is you can actually click on this button and it downloads a little report per indicator, if that's something that you would like as well. And that really closes my presentation. Again, I just want to thank my team who've done a phenomenal job on this dashboard.
Thank you, Carolyn. And over to you, Chair. That concludes our presentation.
Oh, thank you, Carolyn. That's pretty good. Any questions from the board? Speakers? I'll start. It looks amazing. I'm quite impressed by it. I have to say, though, that I did try to find it on the city's website, and the city's website is not the easiest website to find anything on the best of days. So I really do hope that when we eventually have a standalone website for public health, all that information will be transferred over, and the community can actually get this very important information and use it accordingly. Any other speakers on the item? Councillor Chang, go ahead. I can't hear you. You're on mute.
Thank you, Chair. I have a motion, so just put it on screen.
I haven't seen it.
I've worked with staff on it, multiple divisions, and it's requesting the feasibility of adding an intimate partner violence indicator as part of the population health status indicator. As we know, it was declared an epidemic by our mayor when she joined the city, and this requires a lot of divisions because different divisions touch this issue in different ways, but I think this will be helpful. And also just want to thank staff for the current, the current busy, I think is the acronym. Data can inform so much, and I think a lot of our partners and organizations across the city will benefit from access to this data. And similarly, if IPV can be included, I think it will also empower a more holistic approach across our city so we know what we're dealing with. So thank you.
Any questions on this item? I do have a question for the mover. So again, the data, I'm assuming, is collected by Toronto Police.
So actually, it's not necessarily true that only Toronto Police.
I'm asking. I mean, what is the expectation that the data is collected? Where would it get that data from?
Yeah, so I think that is what they're going to have to work out, and they have been working on this. So it's not just coming through this motion. There is a working group in the city that is looking at how data is collected. And so it's just where will this data be housed? And it would not only be the Toronto Police because they only report on the incidents that are reported to them. But we know there's other organizations that serve IPV survivors. And so there would have to be a way to track that data. So this is a motion to examine feasibility, and I think it just furthers a conversation that is already happening.
Okay, thank you. Any other questions? Seeing none, okay. We'll put Councillor Chang's motion on the screen. All those in All those in favor of the item? Opposed, carried. Item is as amended. All those in favor? Opposed, carried. Again, thank you to staff on all this hard work. The next item is 26.4, Downtown Community Outreach Response and Engagement, the core program. Going to turn it to Dr. Lamptey.
Yes, thank you, Chair. So I'm very pleased that we'll have a presentation today from our Acting Director, Sana Imran, our Acting Director of Clinical Services, and Chief Superintendent Kelly Skinner from the Toronto Police Service.
Thank you, Dr. Lamptey, Chair, and members of the board. I'm pleased to be joined today by Chief Superintendent Kelly Skinner from the Toronto Police Services Eastfield Command, and together we'll be presenting an overview of the Downtown Community Outreach Response and Engagement Team, otherwise known as Downtown Core, including some of the key findings and next steps for this pilot. Oh, more? Next slide, please. Thank you. The Yonge Dundas area continues to face complex challenges related to the drug toxicity epidemic and chronic homelessness. And these overlapping issues often create barriers for individuals disconnected from healthcare and social services and have raised community safety concerns while also increasing pressure on emergency services like police, EMS, and hospital emergency departments. The Downtown Core team was launched in December 2024 to address some of these challenges through a health-led, street-based outreach team that is focused on proactive engagement. By pairing public health nurses with police officers, the Downtown Core team enables safe engagement with individuals and allows the team to reach locations that may otherwise be difficult or unsafe for health staff to access alone. And the coordinated approach aims to stabilize situations before they escalate and reduce reliance on the emergency response systems. Next slide, please. The Downtown Core model was informed by other multidisciplinary outreach models, such as the integrating municipal police officers onto assertive community treatment teams, otherwise known as IMPACT, a project in Victoria, British Columbia. So this program paired healthcare professionals with trained police officers and has been in place since 2007. The program had several positive findings, including reduced criminal-related police interactions, including for racialized clients, fewer emotionally disturbed person calls, and less disruptive public behavior, increased mental health responses, so wellness checks, and greater safety for staff, which enabled outreach to higher risk clients, along with lower risk of criminalizing mental health behaviors. This program's model and its successes helped shape the development of the Downtown Core team. I'm going to pass it over to Chief Superintendent Kelly Skinner to discuss a little bit about the program's development, the details, and some boundaries.
Thank you. To develop the Downtown Core program, we engaged local health and community service providers in the now Sankofa Square area. They helped to inform our program's design and align with existing services within our city. Some of the engagement included a town hall hosted by Councillor and Board of Health Chair Chris Moyes, because the area is directly impacting in his ward, to the Toronto Board of Health, the Downtown East Yonge Dundas Leadership Table, the Consumption and Treatment Services Interdivisional Committee, TCCS Citywide Community Advisory Table, and our Toronto Police Service Board's Mental Health and Advisory Addictions Panel. Teams from other Canadian cities, including London, Hamilton, Windsor, Victoria, that have operated multidisciplinary outreach models were also consulted. In our early days, we were looking across the pond to the UK and what they did in Scotland for the Violence Reduction Unit. These discussions provided insights into service integration, outreach strategies, and partnerships that really help shape our approach. Downtown Core is aligned with our health, our city, Toronto's mental health and substance use strategy with SAFE-TO, and Toronto Public Health Strategic Plan, all of which emphasize integrated and community-based approaches to complex health and social needs. Now, this program also aligns with our chief's goals for the Toronto Police Service, specifically to improve trust in and within the Toronto Police Service, which has many different layers, including preventing crime, but also taking a public health approach to addressing the needs of vulnerable community members and re-envisioning community policing while promoting healing and justice at the same time. Ongoing coordination with local agencies and outreach teams remains a key feature of the program, helping to avoid service duplication and improve our response. Downtown Young BIA also plays an important role, leading engagement with local businesses and property managers in the area, as well as conducting an evaluation of the pilot. Next slide, please, and thank you. CORE launched as a one-year pilot program in December 2024. It's a joint initiative, a joint outreach initiative between Toronto Public Health and Toronto Police Service that pairs public health nurses with police officers to address complex health and social needs in our downtown core. This team operates daily from 8 a.m. to 10 p.m., and they do not respond to 911 or 211 calls, which makes them quite unique. They engage directly with individuals based on observed need, using a voluntary, trauma-informed, and a relationship-based approach. This team includes, I think we're at 6 nurses now? Yeah, what's there? 15 police constables, supported by a nurse practitioner, a Toronto Public Health Manager, and Toronto Police Service supervisors up to the rank of inspector. Oversight comes from an advisory committee co-chaired by Toronto Public Health and Toronto Police Service, with members from city divisions and external agencies to guide operations. Next slide, please. Thank you. The slide shows our geographic boundaries, really limited to what was happening in the area at the time and post-COVID. So from the south, it's King Street, all the way up to College and Carleton, west to Bay, and east to Sherbourne. The program operates in the downtown east, really with a focus on Sankofa Square and surrounding neighborhood. This area was selected based on consultations with local stakeholders and due to a high concentration of individuals experiencing multiple and intersecting challenges, including homelessness, substance use, and mental health issues. And I'll now pass it back to Sana to go over how the program works, the current service metrics, our evaluations, and next steps.
Thank you, Kelly. So the Downtown Core team proactively delivers street-based outreach to individuals experiencing homelessness and challenges related to mental health and substance use. They use a non-enforcement approach to public safety by delivering services. So they're providing wellness checks, health education, supplies, clothing, food, naloxone, safer use kits, safer sex kits. They also offer short-term case management up to 90 days. Through the program and through that case management model, clients are being referred to housing, primary care services, substance use treatment, and other critical health and social services. Next slide, please. This slide highlights some of the cumulative service metrics since the program launched in December 2024, showing the overall scale of outreach and engagement. As the chair mentioned earlier, between December and June alone, the Downtown Core team has engaged with over 3,500 clients, 240 of which have been client-initiated engagements. So that means that a client may see the nurse and police officer out on the street and engage them themselves, as opposed to the nurse making that first connection. Next slide, please. We've highlighted just a few testimonials from clients over the past 6 months, speaking to the response from individuals who have engaged and been engaged through the work of the Downtown Core team. I won't read these out to you, but they are in the deck for your review. Next slide, please. So as the pilot progresses, both Toronto Public Health and Toronto Police Services are conducting independent evaluations of the Downtown Core team. At TPH, the internal evaluation is focused on 3 key areas. We are firstly examining the program's impact on meeting clients' health and psychosocial needs. Secondly, we're assessing whether the Downtown Core program has delivered on its intended goals. And third, we're identifying the key enablers and barriers that have affected service delivery and client care. We will report on the results and recommendations of this evaluation to the Board of Health in the first quarter of 2026. I'll turn it over to Kelly to speak a little bit about the TPS evaluation as well.
So the goal when we were first designing the program was to seek to reduce vulnerability and emergency calls for service, really which were related to disorder, crimes of disorder. by increasing access to health and social services for marginalized individuals in the community. Thus, that would directly impact on community safety and well-being for everybody. Professor Doug Thompson from Humber College has been engaged by the Downtown Young BIA to conduct this evaluation of the pilot, and we are working closely with Professor Thompson, who also evaluated our Neighborhood Community Officer program. The pilot will be measured and evaluated using the following metrics amongst those suggested by Dr. Thompson. So we were really looking to see the number of referrals of vulnerable individuals to the appropriate community agencies, evaluations from all members of the town core team, the nurses, TPS staff, as well as feedback from local public health providers, housing providers, clients, and our downtown core team advisory group. And then again, the number of reports related to community disorder and public perception and frequency of overdose activities, which changed drastically from the beginning of the program to where we are now. So many changes have happened. Professor Thompson has already provided some very early and valuable and simple feedback about ensuring that the officers' uniforms are more readily identifiable as core. So we've started to engage in making changes to uniform. And looking at engagements, which was really thoroughly defined by TPH. So it wasn't just a walk by, a hello and a wave. It was, what are we engaging with and where are they going? But he also said that we should also be counting the hellos, that community members who have had a history of estrangement with police or issues with police, just that hello and that common, seeing them often really does have an impact on their perception of police. So yeah, we were looking into changing that separation of that definition, and this is where we are now, evaluation.
Thank you.
Okay.
Thank you. Any questions from the board? Go ahead, Director Ozade.
I just want to say first, thank you so much to public health staff. I know a couple of folks in my network who were straight nurses, and they've told me how intensive but also needed this work is. I was looking at the service metrics and impacts, and I know you're still going to do the evaluation later, but I'm curious about what are some of the preliminary things that you've seen, and also if you can just speak briefly on the psychosocial supports that are provided.
Psychosocial, I could talk about.
Thank you for the question. Through the chair, yes, I'm happy to speak to some of the metrics that we've highlighted in the slide. So, for example, if you look back at the slide, as I mentioned, there were over 3,500 client engagements, which Chief Superintendent Kelly Skinner described as more actual engagements by the nurses to understand what a client may need, where an appropriate referral might be, what are they connected to, as opposed to just a passing by or a hello. 240 of those were client initiated, which were very positive for us to see because it showed that clients really wanted to engage when they saw individuals that they felt they could be comfortable connecting with. We see here responses to clients in distress. So this was also an interesting one because we are not, as Kelly Skinner shared, reachable by 211 or 911, but there have been instances where a nurse and an officer walking by may see a client who, or I shouldn't say client, an individual who may benefit from connecting with someone, and so they would reach out themselves and understand how they can help them get to the right service, whether it's through Downtown Core or another service. There have been several business engagements because that has been a core part of this program as well. We mentioned the role of the Downtown Young BIA, so a lot of work to understand what are businesses seeing as well, and perhaps connections to go more regularly to certain sites within the program boundary areas. Lots of articles of clothing distributed, food items. A lot of these are through donations, which we're very fortunate to receive, and clients have been benefiting, especially in the winter months. Harm reduction supplies, which is of course a core part of the TPH work that we do, as well as primary care services. So that is one of the benefits of having nurse-led interaction, is that they are easily able to assess what might a client need, whether it's psychosocial or primary health care, and then either provide that service on the spot spot or take them to the spot where the service can be provided. In terms of psychosocial, more specifically, it may start off as a wellness check to understand what is the need that is required here, how is the client doing, are they connected to any services, is this a mental health need, is this a primary healthcare need, do they need to be taken to an ER? So it really is more of an assessment process to understand what needs to be triaged here and then support that client in getting access to the right area. I'm going to ask Kelly Skinner if she'd like to add anything.
You know, in relation to working with the encampment team at one of the city divisions, is instead of coming in and clearing people out, they spent the time leading up to that, and I think there were half the number of tents because they connected people. So it's connecting to homes, connecting back with family, connecting them to right services. And what I found so interesting, and it was something that I didn't know throughout this, is seeing why the people were saying that they were homeless or why they were where they are and what they were seeking. And the majority of it is, I need identification. I need access to, so bringing services to people who didn't know how to access it, didn't have the ability, they don't have a phone, they don't know what time it is to get to appointments. So really bringing primary care, I think, has had probably the biggest impact. So making those relationships and connections, connecting people so they're not being moved from one section to another and getting them longer lasting like care and home care, and improving that has been huge. Partnerships. So I think just recently with St. Mike's, they have the academic family health. So they're really just connected, our officers are connected with them. So they run family doctor and patient care to community members in need who might not have access. So really is a gap that we're seeing is after that 90 days, where do they go? So now we have a direct off-ramp for the nurses to be able to connect with this group. So they're working on that right now. So these are some of the things that have really, you're seeing the change and the impact and the value that CORE brings.
Wonderful.
Well, thank you so much.
Thank you. Any other questions? Go ahead, Dr. Zhao.
Thank you for telling us about this program, and I can definitely foresee that it expanding with closure of safe consumption sites. Related to that question, because of the closure and transition to heart hubs, how do you anticipate potentially increased client engagements? Is there anything that you're doing to plan for that?
Through the chair, that's a great question, and it's one that we're still measuring the impact of the closure itself and how has that resulted in a change in services across the downtown core. But one of the things that this team is really focused on is the intersection between homelessness and mental health or substance use challenges. And so in our impact, we haven't actually responded to as many overdoses as we probably may have expected. It's been actually fairly low. The team has really been focused on supporting individuals who are not connected and who need the service, especially as a result of being homeless. And so we aren't seeing too much of an impact yet, but it could be that it's too early for us to discern those impacts, and we are going to keep a very close eye on it as well.
Okay, thank you. I'm going to have two quick questions in the interest of time, because we could spend a lot of time talking about this. And I'll just ask both questions. So do you have a full complement of public health nurses and officers for the program? And second, this is a leading question just so that you say it out loud. Have you secured an office, and who's paying for it?
I can start and then ask Kelly Skinner to add. So currently our nursing complement is at 5 and our full complement would be 6. And we are still recruiting for the role of nurse practitioner. That has been a harder to fill role we have found for TPH, but we are still continuing with that and have been pursuing it with people in equity centrally. Would you like to speak for the constables?
So I think the original commitment, and it would have been 2023 in the budget, was to develop some sort of a team to address this work, and 25 officers was the original commitment. And I think with the nurses, it was in-house. You were going to be finding the work in-house. So we have our 16, and we're ready to go to 25. But I think the focus has to be that the nurses and the balance has to be there, so we don't look like a huge team of police officers, surrounding one nurse. And I think it kind of defeats the purpose. So while we can get there, what we've decided to do is we have our general constable development program, where younger officers who do 6 months training with the community or the neighborhood community officers, if they're in a division that has a similar underhoused population or facing similar challenges, we've just asked them, we just started this summer, to say, is there one person that a unit commander identifies that would be a good fit for this team? Because it's very, very important that the right officers are on this team. And so I think we just had an officer or two come for the summer. So they're working alongside to kind of see, and then they can bring back what they learn here to 55 division, 212 division, 213 division. So we're working on expanding that, but it is pilot. So we can't, dedicate that as a permanent thing. We'll have to see what happens after the year.
And to your other question, for the chair, this team is currently touching down at a space in Cadillac Fairview, which has been provided with the support of TPS, Toronto Police Service. And our plan for the long term, what we faced was our move out of 277. So initially the plan was that the team would touch down at 277 for the nurses, of course, and then they would be close enough to Cadillac Fairview to work very closely with Toronto Police Service as we needed. But with our move out, the plan is actually that we are securing a permanent location for this team to touch down, and that would be coming once we have it renovated and ready for use. Anything you'd like to add?
And Cadillac Fairview has graciously decided to open a space for us. We've always had a substation within the Eaton Center, remember that growing up? And so we've been without that space for a number of years. So they volunteered or said, with our assistance, of course, to create a space. And it was important to have kind of a neutral space, not in a police station, maybe not in City Hall, where the officers and the nurses can meet. We want them out and in outrange, but a place where they can meet kind of neutrally, have meetings, do debriefs and briefings as a team. So they're working on building that space for us. It's taking some time.
And the space is donated, volunteered by Cadillac Fairview?
Yes.
Okay, so it's not a cost to the city?
Yeah, no, not to the city at all.
Yes.
Minimal cost from us for infrastructure and some technology.
Okay, wonderful, thank you. Those are my questions. Any speakers on the item? I do have a motion. I'll just put it up. It's really, in your presentation, you kind of touched on it already. It's really just continuing to work with the Downtown Young BIA because they have been instrumental in the success of this program, as well as just coordinating with and engaging with the Heart Hub that's soon to be coming, and refer pathways between services and integrated case management. That's really the gist of it. But again, thank you for this great program. I mean, I have seen it firsthand, the value of it. I mean, 6 months to actually engage 4,000 people that are most marginalized in our community. Again, the downtown core is so important for so many reasons, but part of it too is the economic success, of the entire city and the country. And it's easy to actually not see people. We do it. I live here, I work here, and I too fall into that stream of not seeing people as we come to and from work every day. And so it's nice to see that, there are people out there that are, with intention going out and helping people that have fallen through the cracks or just about to fall through the cracks. One of the things people have realized is that a lot of people come from outside the core and stay here, and they don't know how to navigate, the downtown. And so it's nice that the team here goes and engage them, and even perhaps connect them back to their families where they come from. Again, not necessarily from the downtown core, and even beyond our own borders. So there are many testimonials I'm sure you could share with us, but I appreciate the two that you have so far. And thank you to the team. And I hope this program goes beyond just a pilot program, because it really is needed. And as you've mentioned, this is not it may be the first of its kind in the city, but it has been tested and true elsewhere as well, internationally and even across the country. So thank you again for all the work that you do. It's a great investment in people. And again, just one of the great things that Toronto Public Health does, and the great work that Toronto Police continues to do in our city. Thank you. Any other speakers? Seeing none, so I will move the motion. If you put it on the screen. Oh yes, there was a declaration of interest on this item, so we do need a recorded vote.
On Councillor Moise's motion, Councillor Moise, how do you vote?
In favor.
Councillor Bravo? In favor. Abhinaya Chandra Balan? Not present. Councillor Lily Chang?
In favor.
Lindsay Kreshner? Not present. Ida Lepretti? Not present. Charles Azude?
In favor?
Councillor Anthony Peruzza?
In favor.
Suman Roy?
In favor.
Ramanjit Singh?
In favor.
Councillor Michael Thompson? Not present. Stephanie Dow?
In favor?
Thank you. Motion carries.
Thank you.
Thank you.
Okay. Item is amended. Recorded vote.
Councillor Moise?
In favor.
Councillor Bravo?
In favor.
Abhinaya Chandra Balan? Not present. Councillor Chang?
In favor.
Lindsay Kreshmer? Not present. Ida Lepretti? Not present. Charles Azude?
In favor?
Councillor Peruzza?
In favor.
Suman Roy?
In favor.
Ramanjit Singh?
In favor.
Councillor Michael Thompson? Not present. Stephanie Dow?
In favor?
Thank you. Motion carries.
Okay, thank you. We're almost there, folks. Item HR 26.5, Planning for Climate Change Monitoring to Understand Health Impacts and Support Resilience in Toronto. That's not you? Oh, there's no presentation, it's just a report. Actually, there is a, I think there are two speakers. That's why we held it down, yes. Is Dr. Louise Hittinger here?
She's online.
Louise? Okay, go ahead, 5 minutes.
Thank you. I'm a concerned parent, resident of Toronto, and a member of Clean Indoor Air Toronto. It's only the beginning of July, and Toronto has already experienced wildfire smoke and extreme heat. We're faced with multiple overlapping crises: climate change, environmental pollution, habitat destruction, and pandemics or epidemics due to airborne diseases. All of these crises intersect when it comes to air quality. Temperature and relative humidity are components of air quality, and climate change is affecting both, causing extreme heat along with high levels of humidity. Climate change-related events also generate massive amounts of air pollution, whether it's smoke or the pollution kicked up from water and soil into the air by torrential rains. Smoke, car brakes, tires, heavy industry, construction, they all generate fine particulate dust, called PM 2.5. But there's also other harmful air pollution, such as microplastics and PFAS, that are components of this dust. And this air pollution is commonly found in higher levels in urban areas like Toronto and inside our built environments. Climate change is leading to events like heat domes. And during these events, air pollution can accumulate and concentrate, especially indoors. And finally, we've got zoonotic diseases, such as avian influenza, which can be transmitted through the air. Aerosolization of diseases from water and soil due to heavy rains make it more likely for these diseases to cross over into humans. Toronto Public Health's surveillance of health impacts related to climate change includes health impacts of poor air quality. We would like to know if the public dashboard will include the impact of poor indoor air quality. Outdoor air pollution inevitably comes indoors. At the same time, extreme conditions are leading to health recommendations to shelter indoors. However, as we've mentioned in the past, the Ontario Building Code relies on a ventilation standard that was not designed to deal with climate change and is definitely not designed to handle airborne transmission of highly infectious diseases like measles and COVID. Unfortunately, many buildings in Toronto, including our public schools, and many buildings found in lower income neighborhoods do not even meet the ventilation standard. They lack adequate ventilation and air filtration. In many cases, they don't even have mechanical ventilation or air conditioning. In order to better assess the health impact of air quality, we should also know what's happening when people are spending more time indoors sheltering from climate change events. A public dashboard that includes an indoor air quality monitoring system that tracks indoor levels of carbon dioxide, CO2, and PM2.5 along with temperature and relative humidity would provide an invaluable source of data for both the public and for Toronto Public Health. This could be done as a pilot project, for example, with Toronto Community Housing, as well as on a volunteer basis with small businesses and commercial properties. The public would be able to assess air quality in public indoor spaces like restaurants and stores. At present, there is no information on air quality in shared indoor spaces. Posting this information would remove what we see as a major barrier to access for people who wish to protect themselves from the health impacts associated with poor ventilation, whether it's a disease or smoke. At the same time, tracking indoor air quality across a variety of indoor spaces would provide useful data for Toronto Public Health, allowing correlations between indoor air quality metrics and various health impacts. In order to provide a framework for this monitoring, Toronto needs an indoor air quality policy. The city has an IAQ policy to protect its office employees, but there is no policies or guidance for Toronto's residents. Now, this is a matter of urgency because the City of Toronto has a net zero emissions strategy, but it lacks guidance on indoor air quality standards. Part of this strategy includes HVAC upgrades to reduce energy consumption. But we're concerned that this may lead to another version of sick building syndrome, where people are sheltering indoors to avoid climate change events, but these spaces lack ventilation and air filtration that's adequate for removing air pollution and airborne diseases. Now, we recognize that indoor air quality is falling under the jurisdiction of multiple government agencies, but we're urging the board and TPH to work proactively with these other agencies to develop an indoor air quality standard for clean, safe to breathe air that will protect the health of Toronto residents across the lifespan. Thank you very much.
Thank you very much. Any questions for the deputant? Seeing none, thank you. Next up is Harper Jean Tobin. Are you here? Online?
I am, yes.
Go ahead, 5 minutes.
Sure. I'm sorry. Can you all tell me how to come on camera? Or should I just start speaking?
Start speaking.
Okay, thanks. Hi, my name is Harper Jean Tobin. I am here today as the director of the Community Resilience Project for the 519. This is an important issue for the 519 because we serve nearly every community identified, and existing research is facing heightened climate health risk exposure and vulnerability, including to us LGBTQI+ people. We put out a report last year, particularly about those disparities, but also newcomers, unhoused and insecurely housed people, older adults, families with young children, people with mental illness, drug users, sex workers, and Black, Indigenous, and racialized communities. The downtown east, where our expanded catchment is, of course, is identified in recent research as among those with the highest vulnerability to extreme heat in the city. So this is a very important issue for us, and we welcome TPH's plans here. Developing and monitoring a robust set of climate-related public health indicators could help the city better understand unique and local impacts, better target interventions, and evaluate and improve those interventions over time. We particularly support the inclusion of proposed indicators on climate-related mental health, drug overdose, and food security impacts, which are of great importance to the communities we serve, particularly with drug toxicity crisis and the closure of safe consumption sites. With regard to mental health, we encourage TPH to think about ways to address impacts in both directions. That is, how mental health can dramatically affect risks of serious illness and death in extreme weather and other climate events, and also how climate in turn impacts mental health on an ongoing basis. We also think because of the acute impacts in these areas that have been documented around the world but receive inadequate attention in climate and planning and investments, the city should consider accelerating the timelines for these particular indicators, which are currently a little bit longer in TPH's plan. Obviously, we also think TPH should work with communities and public health stakeholders to capture, as it proposes to do, inclusive demographic data where possible, including but not limited to data related to housing status and to LGBTQI plus populations. We of course think local measurement's important, but it should move in parallel with and not delay urgent, bold actions supported by existing evidence. And on that score, I will simply say that we urge the city to consider how we can swiftly act on calls to action, such as those from the Toronto Heat Safety Coalition, of which we are a part, the Health Providers Against Poverty and For Our Kids Toronto, and their comments on this item, while building a local monitoring system to inform iterations on these efforts. We also think the TPH and other parts of the city's responses could benefit from a range of quantitative indicators combined with qualitative or mixed methods ones, as TPH suggests. We think TPH should think about opportunities to fund and formalize collaborations with community hub partners to develop indicators and collect data. Whether that's the AACs, of which we're a part, the city's own growing, the city-led hubs coordinated by SDFA or other established hubs and provider networks across the city. Of course, focus on consulting and collaborating with and understanding health impacts among populations known to be most at risk. We also urge that we should consider additional quantitative indicators as related to causal and risk factors. We already have a couple of those in here. Indoor heat, indoor temperature, and air quality have been mentioned by others. We think those are important ones to figure out ways to incorporate. Also other key social determinants, including, as I said before, related to housing, which might include analyzing these indicators in connection with other data sets, like
Final thoughts, please.
Climate risk and vulnerability assessment, or in conjunction with future policies and programs like building emissions and indoor temperature standards.
Thank you.
So in general, we appreciate this effort. We're going to submit written comments with more detailed suggestions, and thank you for listening to me.
Okay. Thank you so much. Any questions with deputies? Seeing none. Thank you. Okay. Any questions on this item? Councillor Chang, we are very limited on time, but go ahead. I'll give you 2 minutes. That's it.
So I'm just wondering, can the city play the role that is being requested by advocates with regards to indoor air quality standards? And what kind of role could we play in requiring monitoring and transparency of air quality beyond city-owned buildings?
To the chair, I'll start to say that municipal licensing and standards is currently reviewing the property standards bylaw, and ventilation is one of the items that will be examined as part of this review in the fall of 2025.
And so will indoor air quality be included in the dashboard that's mentioned in this report?
To the chair, I'm going to have the team that helped prepare the dashboard provide more detail about what's possible.
Unfortunately, indoor air quality is a subject of research right now. It's very easy for outdoor air quality. You can set up, the city actually has 4 monitors set up by, I think, the Environment and Climate Change Canada with the Ministry of Environment, and that provides a good picture of the city overall. But indoor, buildings vary so much from one to the next. And so it's a really difficult challenge to understand what would even be representative of indoor air quality across a city. In fact, even within an individual building, right? What might be experienced by a resident on the top floor of an apartment could be very different than somebody at the ground level. So it's definitely, I think, a very important area. It's been acknowledged people spend most of their time indoors. However, measuring that in a comprehensive way that would reflect what people overall are exposed to is a really difficult challenge, and it's a subject of research, and it's something, as answers become available, we would incorporate them in our framework.
I know some parents and advocates are saying, at the very least, can we do something about schools, because our kids are in those buildings. And I'm wondering about jurisdiction. What role could Toronto Public Health play in terms of indoor air quality and, our aging school infrastructure?
So to the chair, the Ontario Ministry of Education is the authority over the administration and management of schools, including health and safety measures for a safe learning environment. That includes, of course, indoor air quality. So in that role that they've taken, the Ministry of Education has taken measures such as recommending updates to ventilation systems, and they're responsible for carrying those out. And they've also issued guidance to directors of education and school authorities on ventilation practices and public reporting of renewal projects. So as a partner, what Toronto Public Health does do is collaborate with local school boards and individual schools to promote health through things like information. So we've referred to the packages we've sent out to school boards for disease prevention, including measures like ventilation to be able to protect health. But really the authority for implementing anything is up to the Ministry of Education.
Mm-hmm. Thank you. Those are my questions.
Okay, thank you. Any other questions? I have questions. Councilor Bravo.
Thank you, Chair. Just wanted to look at the, in 2023, when we directed that this work be done, there was specific mention about indoor and outdoor contexts. I don't see it in the plan. Are these barriers here are there barriers for TPH staff to understand how heat impacts vary from indoor versus outdoor?
Yes, to the chair. I think Dr. Shapiro will add to his previous comments.
Thank you.
Outdoor is something that's readily available. Indoor is very hard to measure. Nobody's doing this routinely as far as I'm aware. And I checked with my colleagues from environment. I can't remember the rest of the division's name now, but as well, they're not aware of something that's routinely or regularly available. Conditions vary so much from place to place, or even you could have the exact same structure and people may use the home differently, and then you get a different indoor air quality reading. So right now it's a really big challenge, and it's a subject of research.
So you don't have a data set to rely on, and then does that make it very challenging then to go beyond looking at outcomes into causal factors, and therefore it makes it challenging to make recommendations for interventions that would improve the indoor piece at a population level?
Through the chair, I think there are ways to get at some of the causal factors. It just wouldn't necessarily be through some sort of routine surveillance or database. I think there is potential information available as well. Having good information about the environmental conditions outdoors still provides some indication of what's happening indoors. It may not be able to say at an individual level what's going on, but I think there is some sort of correspondence between outside and inside.
Great. And last question is, did you look at the British Columbia's extreme heat death review panel report at all? Did that come into play in terms of, I see a head nodding.
Yes.
Okay.
Yes, that was, it's something that we reviewed at the time it came out because heat's an important issue, even before we undertook this endeavor, and it's something we've looked at now as well in drafting the report. The coroner in British Columbia collects different information than what's available here, and so we can't necessarily replicate exactly what's been done there with respect to coroner's data.
Okay, thank you.
Okay, thank you. Seeing no other questions, we'll go to speakers.
Sorry, Chair, I have a motion that clerks are working on, or has been sent in, I'm sorry. No? Okay,
Just came
it's in
through.
my email. Could you hold this down when we go to the last one?
Okay, we do have a 2 o'clock meeting.
Yes,
We have to get to, but
I'm aware.
okay, I'll hold this item down. We'll go to the next
Thank you.
item. HL 26.6, update on the Alpha 2025 Annual General Meeting and Conference. Director Ozude wanted to speak to this item.
Yes, really quick. And thanks for everyone for staying this long. Yes, earlier, or last month, because we're in June now, I was at the Alpha conference. For those who don't know, Alpha is a nonprofit organization that provides leadership to the Ontario Boards of Health. And just wanted to highlight a few things in the conference. Like the general themes were really on deepening partnerships across public health and healthcare systems. There were sessions on Indigenous reconciliation and also navigating the health and political challenges we're facing. As I was creating this report, I thought maybe it'd be good to highlight some key takeaway for the boards. And we had a session on public health engagement with Indigenous communities, and the key takeaway for the board is, like earlier this year, we had a board session on Indigenous cultural safety, and the main thing here is for us to keep in mind that the work of reconciliation is deep and it's ongoing work, and for each board member in our work, but also in our lives, to also take part in continuous education and listening. There was the part on understanding Ontario's political landscape, try to, weave in the context of public health and the political context that we work in. And for the board, the main thing is for us to understand now that, especially in the post-COVID era, political and national boundaries have been blurred. So an important thing for us to will be to stay vigilant and locally informed, but also globally conscious. And then finally, we had a provincial update from the Chief Medical Officer of Health on the measles outbreak and the collaborative work that they're doing with the federal government. And as a board, one thing to keep in mind would be that as we just keep collaborating with the healthcare sector, our work is still rooted in social determinants of health. And I love that, this is something that's being weaved into our strategic plan. And it would just be good for us to keep it in mind going forward. So that's it.
So those are some interview
Thank you. Any questions for Director Ozude?
Yes.
Seeing none, thank you so much for attending and for participating and providing the feedback to us. I'm going to, any speakers on the item? Okay, I'm going to move a motion for receipt, right? All those in favor, opposed, carried. And that takes us to our last item. Is it ready? Yes. Okay, so I'm gonna have Councillor Bravo speak this item.
Thank you, Chair. So this, the motion while it's being displayed really gets at what I was raising in my questions. And it asks for the Medical Officer of Health to include where possible and applicable, and as part of tracking and reporting of the health indicators outlined in the report, the disaggregated indicator data, which is really focusing on whether it's outdoor-indoor exposure question, and that one of the potential ways to look at it is the rate of emergency department visits for heat-related illness from outdoor exposure, and separately, rate of emergency department visits for heat-related illness from indoor exposure. And we have a lot of questions around this in the community, a lot of interest in this question of the impact of heat on health outcomes, particularly among vulnerable populations. And from the things that we deal with at Economic and Community Development Committee, for example, the questions of, is it, for example, a tenant in a rooming house versus a person who's unhoused? And these are this is where this kind of interest is coming from, so that we can track those outcomes. And I've spoken to staff. I thank you for answering my questions and for taking a look at the motion.
Okay, great. Any questions of the mover? Seeing none, okay. Let's display it and vote on it. There we go. All those in favor? Opposed? Carried. Before item as amended, all those in favor? Opposed? Carried. Just want to take a time to thank staff for all the work that they do, but also too for pushing through today. I know it was a heavy agenda with a lot of heavy discussions. So thank you to everybody, and thank you to the board. I know you guys are troopers, and we do have another meeting after this for a budget, a subcommittee, starting at 2 o'clock. So 2:30 apparently. So enough time to take a bathroom break and have some lunch. So that concludes our business for the day, and have a good afternoon. Thank you. Thanks.
Thank you, Chair.
Thank you, everyone.
Thank you, everyone.